Welcome everybody. No, non è spento. We take a seat so that we can start the day. So good morning, good afternoon, everyone, and welcome to Parma to the very first edition of inTRACE. We are truly honored and delighted to have you here. In these days, we will have 250 participants coming from the clinical world, from research, turning over and rolling over these days and these interactive sessions, coming from Italy, Europe, and even outside. So we are very grateful for your participation and the enthusiasm that we gained from all of you. Your presence, in a way, confirms that the topic of intracranial recordings is not only timely, but very vibrant and lives at the edge between the needs of clinics and research at the same time. The core idea that stands behind this conference is exactly this: to create a dialogue between research and clinics, all finalized to the patient of tomorrow, to the enlightening of the neural mechanisms that live in his brain, and at the same time to the exploitance of these mechanisms for tailoring the diagnosis, the prognosis, and his treatment. Thank you all for being here, but let's get started for this thrilling journey, one that I, together with Andrea, we must confess, we are truly, truly excited about. Every meaningful journey, however, needs solid basements to start off. And by basement, by grounds, what I mean is cities, cultures, schools, mentors, all premises that are absolutely necessary for a successful journey in any field of our experience. So before we dive into the heart of the conference, we have the privilege of welcoming a few but truly eminent representatives of these basements. Unfortunately, we had the acceptance of the mayor of Parma City, who, with a business, with a staff of last minute, couldn't attend the conference, but he cared in saying us that he would have loved being here and witnessing how research is not something pertinent exclusively to labs and hospitals, but also to the city and to the community in which research happens. With not less enthusiasm, we have the privilege of having here the Dean of Parma University, who embodies the academic tradition and the forward-looking spirit that we want really to incorporate in our meeting. And for this reason, I invite here Professor Martelli to give his welcome for the opening of the session.
Good afternoon, everyone. I'm really pleased and honored to welcome you on behalf of the University of Parma to the Congress inTRACE, charting the intracranial connection between clinics and neuroscience. We are thrilled to host this exciting event that brings together leading experts, researchers, and practitioners from various fields dedicated to advancing our understanding of the intricate connection between clinical practices and neuroscientific research. This Congress represents a vital platform for exchanging ideas and fostering collaboration in a rapidly evolving field. The intersection of clinical insight and neuroscientific discoveries is crucial for developing innovative approaches to diagnosis, treatment and patient care. We are witnessing unprecedented advantages in our ability to map and understand the brain, which allow us to refine our clinical practices and enhance patient outcomes. Throughout the next few days, you will engage in stimulating discussion, share groundbreaking research, and explore cutting-edge methodologies. I encourage you to take this opportunity to connect with one another, share your insight, and forge lasting collaboration that will propel our field forward. I would like to extend my heartfelt gratitude to the organizing committees, speakers, and all those who have contributed to making this event possible. Your dedication and hard work are truly commendable. As you embark on this intellectual journey together, let you be inspired by potential and lies in your shared knowledge and collective expertise. Together, you can chart new paths in understanding the complex working of the brain and improve the lives of countless individuals around the world. I wish you all a successful and enriching Congress and look forward to a fruitful exchanges that will take place over the coming day. And particularly, I encourage you to enjoy also Parma, good food, and also some good wine. It's a very, very good opportunity to improve your knowledge and to share particularly friendship. Thank you for coming and welcome to Parma. Thank you.
Good afternoon to everyone. I also join Pietro in greeting all of you, the speakers, the sponsor, and above all, eBrains Italy, without whom it was not possible to be here all together. And this workshop wouldn't have been possible without a venue, and what a venue actually. So we would like to warmly thank Crédit Agricole for providing us with a splendid auditorium and for the entire duration of the workshop. And a special thank to Francesca, Riccardo, Davide, Luca, and Gino, whose support and friendship have been of tremendous help for us for the preparation of this meeting. And here to bring us greetings from Crédit Agricole is Dr. Vittorio Ratto, General Manager of Crédit Agricole.
First of all, good afternoon and welcome to everybody, to all the guests in this room, to the speaker that will attend to this conference, to the Magnifico Rettore, all the scientists and people involved in this field of study. I must say that it's truly an honor, it's a pleasure to welcome all of you for these days here in our headquarters, which is really our home. We call it Green Life. It's really the place that we built as the headquarters of the bank. And it's a sort of really representation of what we care about. So you see a lot of green, you see all buildings which are completely eco-sustainable, so we are certified. You have the chance to stroll around the park. I suggest you, if you have the chance in these days, to do it. Today maybe it's a bit cloudy, but in the coming days there should be sun. You see there's a cafe. We also have a couple of hives. We produce honey, not too much, but it's still something that we do. And so entering this because it really represents one of the elements of the spirit that we try to sustain and really a fundamental piece of the bank. First of all, I would really like to thank the University of Parma. We have a strong relationship together. We do many things, from services to the students, to participation to lesson, also to organization these events. I think it's something to nurture and that we are proud of. And then, if we go more deeply in the subject, I think that we live in really extraordinary times for many different reasons, especially in terms of scientific discoveries. We are seeing a lot of things that are happening in the world, especially where all the science blends together at these boundaries, this edge. And I think somehow this is a good representation. It's also true that we are seeing also many signals that not everything is positive. There are a lot of things happening in the world that go in the opposite direction of more boundaries, more things closed. So again, I think this type of events, also placed in an institution like this one, is a very good occasion to remind to all of us the things that are important. And for us, as a bank, as a financial institution, you might think, what is the relationship to this particular field? Well, in general, we are curious people. We like to invest. We like to support our clients. We like to support company, entrepreneur, university, and all the communities. And we think that in this environment, this particular field of studies is really something cutting edge. We strongly believe that. We also do some internal training around concepts linked to neurosciences and development of people and investment of people. Because at the end of the day, this is really the key points of what we all do. So we believe in people, we believe in person, we invest, and this is a truly wonderful occasion to discuss about these issues. I must also confess that I'm a voracious reader of these topics. A bit on the popular side, not very scientific. I'm not really sure I understand the title of the conference, but I like the subject. And also, I must admit, normally dinner time, during when we have dinner together with my family and my two kids, I always speak about these topics that I read. And normally the reaction is not again neuroscience. So I'm looking forward to go home and say, you know what, I open an international conference on these topics. So with all my pleasure, my heart, I welcome you again to this conference. Enjoy it. I really hope it's fruitful for everybody. And as I said, if you have the chance, go around, have a look at what is today a bank. We are the first European banks in terms of retail activities. So we care for people, for our clients, and enjoy it. Thank you very much.
As Pietro mentioned, we are here to try fostering circularity between clinics and neuroscience. But we must not forget that there is a third fundamental actor in this story, which is patient's health, and which is the fundamental actor in this story. And that is the reason why we are here, and why neuroscience and clinicians must speak and must communicate all together. Tomorrow's patients will benefit of this communication among us. Here today we have with us Isabella Brambilla, mother of a young man with Dravet syndrome and a tireless advocate of patients with rare epilepsies. Founder of Dravet Italia Onlus, she established the National Dravet Syndrome Registry, now expanding to European level, and co-founded the Dravet Syndrome European Federation. Her advocacy work extends to the European Network EpiCare, a scientific sponsor of this meeting, and Rare and Complex Epilepsies Alliance, promoting collaboration and protection of patients at every level. It's a great honor to introduce Isabella. Please, Valerio, can you project the slides?
So thank you very much. It's an honor to be here and to represent also my big group of patients. So I don't know, it's not this one. And thank you for the great presentation. I start as usually personal individual experience when my third son was diagnosed with Dravet syndrome. But I tell you, it was very important to have a name and to know the journey, but more important and devastating was really how to manage that. Because there, at the moment, doesn't exist an effectiveness cure. We search a cure for living better with that. For this reason, we try to work and create more and more network, starting with the Dravet community in Europe, and then with all rare and complex epilepsies. And I thank EpiCare to give the honor to drive in the patient community since 8 years. What does mean representative European community? We have different associations, different countries, is amazing fragmentation of duplication of association, barrier of language, and a lot of patient involvement in a different country. What does mean representing all rare and complex epilepsies? A huge number of names, but for us an only name because gene, the majority are new gene discovery, thankful that we can understand better the onset of the disease and the reason why, but only few of them have the opportunity to have a specific cure, as Dravet syndrome, for example. We are running now and faster the gene therapy. Only few of them, they can have a surgery to try to solve the solution. But for the most of them, doesn't exist a cure. We try to monitor only the symptom. Which are now the question for the patients and why we try to strong the community together. The names are different and the diagnosis and onset are different, but we have in common the same question. All of them have epilepsy, seizure, different type of seizure, but at the moment, as I tell you, is a lack of treatment and we don't understand exactly the disease. For example, the same gene generated Dravet syndrome, but also only Jeff's plus. And also, what we don't understand, the spectrum that have these children, because the spectrum is very high. We have some severity, moderate, and only borderline patient. So maybe we don't, at the moment, are able to understand everything. But what is more important, we know as patients that is not only an epilepsy. We have a cognitive behavior, sleep disorder, speech problem, movement disorder. A lot of them have enrolled chair, and a lot of them have difficulty to do a normal gait. Speech, we have a lot of children are not able to speak. A group of them only some sentence and words. So I think become with this also, they call it comorbidities. From my point of view, is more the comorbidities are part of this complexity of disease, started by the symptom epilepsy. But I think it's very important that we go deeper to understand a little bit more, because the quality of life for our family is devastating, not only for the epilepsy, that I will explain a little bit to you better that maybe you don't see a patient. Our epilepsy is drug resistant. The type of epilepsy is very different. We have amazing number of seizures. My son survived 500 seizures in 1 year. We need to take care of these children 24 hours because we have a seizure during sleep, awake. We need to take care because when they have a seizure, they falling down, we have an accident. If they swim and they can death for accident. And also we have the SUDEP, a high risk of death, unexpected death. It's very huge, the percentage of patients that died every year also with this type of the disease. And this is what is mean living with this type of children. Not only the epilepsy problem, but also the cognitive behavior and also the non-autonomy make impossible for them and for their family make a quality of life. As I tell you, we have at the moment drugs that try to contain the seizure. We're waiting for gene therapy that's coming soon, especially for Dravet. We have surgery, but not for all. But the understanding comorbidity is the major priority now for the patient, and they want to run in to understand more this important aspect. What we are doing as patients, we wanted to create a bridge between physician, researcher, and the needs of the patient. How we can do that? We try to support you if you need survey, collecting data, registry. We're working with a major European project in research as Herdera now. In the past was the Horizon. We have also the Italian PNRR, la ricerca. We have also Epicare. We have also a European joint project that running before Herdera. We try to support you with data and real-world data as you need, to working together to understand more how you can help us and how we can support you in this research of helping. These are one example of the publication that we are able to do together with you and with the patient organization. We try to drive in also some small project, but very important for us. Understand more the gait analysis, invited the patient to participate in the project of research. Make also all publication that we are able to do in a lay version, understandable also for the patients. But I have some question for you that I wanted you try to answer during your Congress. Why the researcher and we continue to focus only on treating the symptom when it's only the tip of the iceberg? How we can expand research to adopt more holistic view for this disease, and why we don't study more the comorbidities, sleep disorder, cognitive behavioral, psychiatric disorder for all patients. What electrophysiology and investigation strategy can implement to address underlying issue behind just seizure? So it's a message that I want to give to you. Thank you for your work. Thank you for continuing research. We hope that everything, and especially your work about the technical and new tools, can support better to understand the big phenomenon of our brain and to understand better how we can give more information to the clinician, to understand how they can help us try to understand more the disease, try to treat them, and to have for these children a better future. So thank you very much and have a nice Congress.
Thank you, Isabella, for witnessing this very important perspective that values even more how this synergy has to happen between all the layers involved in epilepsy. Now, last but not least, we are in Parma, and let me tell you, basically, when one talks about Parma and neuroscience, there's one name that stands in all our minds, that is Giacomo Rizzolatti, that basically has been the father of several research lines, research groups, discoveries that all of us know, and most of us get in touch with on a daily basis. And literally, even intracranial recordings make no exception. It was 2008 when, for the first time, Ivana Sartori, who will kill me for having quoted her later, contacted some researchers of Parma University and kind of triggered the first expeditions from Parma to Milan to kind of reason about how the electrophysiology of the motor system could explain, contribute, and value the observations that they were making on some epilepsies involving the motor system first, and the insular cortex later. Different researchers, different people have attended the Niguarda Center, and all of these activities lied under the umbrella of the research lines headed by Professor Rizzolatti. This is why we have the privilege of having him here, and we ask him to kind of recap the reason why this started and the reason why it should continue and even be strengthened over time. Thank you.
I must say at the outset that I am very happy that this meeting takes place in Parma. And I'm very grateful to Pietro Vanzini who organized it, not only for the work that he said about me. So in this short talk, I would like to summarize why we decided that this new technique, surgical technique, it's very important also for us. I think all of you would agree that the golden age of neuroscience was immediately after the Second War. After the Second War, the technical progress allowed us to understand the mechanism before, thanks to Brodmann, von Econom, and many other anatomists, the clinical work. We know that occipital lobe is for vision, parietal lobe is for other things, and so on. But we knew nothing about the mechanism. It was after the war that this type of information started to be available. And I must mention, first of all, Huber and Wiesel with their work on vision. They showed that how occipital cortex, visual area, analyzed the external world. Immediately after, Charlie Gross in Princeton showed how this is synthesized, the famous grandmother cells of the time. Almost simultaneously, the parietal lobe was studied by Hivarinen in Helsinki, Mountcastle in Baltimore, and Sakata in Japan. And finally, in Parma, we started to work on the premotor cortex with many surprises, including the fact that a premotor area, so an area whose stimulation produced movement, responded also to visual stimuli. And one of our discoveries were the mirror neurons. Then something happened. At the beginning, at the last century, at the end of last century, beginning of this century, appeared brain imaging. It was like a dream, how you can record from a brain of a person who is doing nothing, just thinking. It seems almost a miracle. And also this technique allowed us also to increase our knowledge that before was mostly on animals, on humans. And again, thinking about Parma, in collaboration with Milan, as a matter of fact, with San Raffaele, we were able to show that mirror mechanism exists also in humans. Then it was a flood of data with brain imaging, data on, for example, in our case, it was the possibility to demonstrate that mirror neurons is not related only to premotor cortex, but is related also to emotion, to empathy, and so on. So it was a big progress. However, at a certain point, there were some problems. One minor problem, I think one can discard, is phrenology. There is a paper which claimed that we have discovered 92 new brain areas in the brain. Von Econom described only 56. So, but that doesn't matter. I remember talking with Carl Sears, he don't care. We can disregard that. But there were some points which were really weak in brain imaging. Time. Our life is in time, but if you look at the brain imaging, it's just picture, no time. Then correlative errors. There is some interesting review which claim that singlet, I don't know how many function. For example, pain should be there. It's not true. And beside that, what is could be correlation, time, and the situation is extremely non-ethological. What you say to your patient, the first thing when you are in the magnet, don't move. Please stay still, because otherwise will be only artifacts. So how to overcome these three major points? Time, correlation, non-ethology. So at this point arrived a call from Niguarda, was Ivana, just mentioned before, who said, listen, we have plenty of data, and we are a hospital. We need some help from you. Maybe you are more free than us, that we are very busy with patients. And with collaboration with LoRusso, who is here, we decided, well, that's maybe an opportunity. We went to Milano, and we were enthusiastic of what we can get. Thanks to Pietro Vanzini and Abdullahi, who was a technician of Giorgio, we made some modifications so the data can be averaged, increased, and so on. And we started to work with them. And we have many papers, but one, for example, is very simple. If you imagine the stimulation of medial nerve, something which is done routinely in this technique, then you see, first, if you look only at time immediately after the stimulation, what is written in any textbook? Activation of somatosensory cortex. But if you look in time, after a while, the greatest activation is in the premotor cortex. And if you wait for 100 milliseconds, the greatest activation is in the periselvian gyrus. Why? So you see how it opens new horizon, also conceptual new horizon. Why it should be after 100 milliseconds, something in periselvian gyrus, when the somatosensory cortex already forgotten about that. And with pain, we made many experiments on cingulate gyrus, especially with Fausto Caruana, and we found that in the posterior part of the arcuate, of the cingulate gyrus, in the posterior part of anterior part, the stimulation produced laughing and joy. There was a very intelligent student who said, listen, doctor, it's not me laughing, it's something inside myself which is laughing, which was very correct. But that was the area for mirth and laughing. With Fausto Caruana, then we tried to see if there is a mirror system for that, and there is. If you present a laughing face, you have an activation exactly of that. Then there was a disaster, COVID. COVID was a disaster because this great collaboration collapsed for a while. Now it's growing again, and I hope that we can start again with the great result we got before the disease. Thank you.
Thank you again, Professor. And before moving to the first keynote here, let me thank again all our guests. Just a technical note, Valerio, please check the streaming because it's not working. And now we can start with the first keynote. And I must be honest, I've struggled a lot to find the right words to introduce Marcello Massimini, because he's not just a mentor. He's a scientist that profoundly shaped my scientific path. So I found I tried to find the words, but actually I decided to say his story briefly, very briefly, almost as reported on the website. And Marcello was trained as a medical doctor, had a PhD in neurophysiology, and is currently professor in physiology at the University of Milan, as well as a fellow of the Canadian Institute for Advanced Research. He worked in Canada in the lab of Michia Steriade, the researcher who first observed the intracerebral dynamics underlying sleep slow waves. Later, he moved to the University of Madison, Wisconsin, where he worked in Giorgio Toloni's lab, pioneering the use of TMS combined with EEG to study changes in effective connectivity during sleep-wake cycle. And upon returning to Italy in University of Milan in 2006, if I remember well, Marcello began a new chapter with Mario Rosanova, an adventure that is continuous to this day. And since then, Marcello has dedicated himself to studying the mechanism behind the loss of and recovery of consciousness and function in the case of brain injury, with both invasive and non-invasive electrophysiological techniques. He has been part of the Human Brain Project, and recently he won an ERC synergy with Mavi Sanchez-Vivez, Maurizio Corbetta, and Gustavo Decco to study brain lesion in humans, and also using intracranial recordings. It is with my great honor that I introduce to you my mentor and above all friend, Marcello Massimini.
Can you hear me? Yes, okay.
Valerio, can you start the presentation there, please?
Well, meanwhile, thank you, Pietro. Thank you, Andrea, for organizing this amazing, it's an amazing meeting. I think I've seen the program, it's really fantastic. And unfortunately, I will have to leave because I have to go to the US where the previous commitment, that's why I'm the first speaker, I guess, because I have to leave. Also because, you know, among you, I'm the least expert probably in intracranial recordings. You know that, or most of you know that I'm not really, you know, I don't have a strong direct experience in this, but I think I'm in a position to witness how fundamental intracranial recording can be in shaping clinical research trajectory. This I know, because I have experienced that myself, and I'll try to share with you, you know, at least my experience in this. So my first disclosure is that, of course, I'm not an expert. Here are the experts in my lab: Andrea, Ezequiel, Francesca, Serena, Marta, Alessandra, most of them are here. And they work tightly with Niguarda, most of Niguarda is here, and with Parma. So it's a team, really beautiful. Second disclosure is, you know, I have some, you know, grants, but most important, I have to disclose that I became recently founder of a company, and this company is involved in developing TMS-EEG. I will talk about TMS-EEG today, so that's why this is a relevant disclosure towards a clinical tool. That's all. We will probably fail. We are all scientists. It's going nowhere, but I have to say that. Well, okay. So now, you know, coming to my presentation, what I'll try to do is to start from the surface of the skull by showing that by stimulating the brain and recording EEG responses and then computing complexity of these responses, you can derive useful markers, objective markers of recovery of consciousness after severe brain injury. Then I will dig deeper into the brain, and here intracranial recordings and stimulation will play a major role to show and try to elucidate the mechanisms of loss and recovery complexity, and thus loss or recovery of consciousness. And specifically, I will point to an interesting mechanism that is called neuronal bistability. Basically, the fact that neurons, under some condition, they tend to go into a silent hyperpolarized period after initial activation. This is the basis for slow waves. It was basically discovered by Mircea Steriade, a great neurophysiologist. I had the pleasure to work with him during my PhD. And I will also show how this bistability, not only it's relevant for, you know, loss of consciousness in sleep, severe brain injury, vegetative state, but also in determining functional network disruption after more focal brain injury. So the common denominator of my talk is going to be these slow waves and the underlying neuronal process. And of course, here, intracranial recordings are the fundamental bridging principle between neuronal processes and global brain dynamics. And they will come back and forth, you know. And also, as I go, I will point out to some of the beautiful, abstracts and talks that I've seen on the program when relevant. So let me start from the clinical problem. The clinical problem is that of detecting consciousness in patients who emerge from coma unresponsive. Well, normally the gold standard is actually to test behavioral motor responsiveness, as you know, according to different scales, and they rely on the integrity of sensory inputs, sensory processing, executive functions, motor outputs. When it works, it works. Positive results are unquestionable, the patient conscious, but the absence of the proof is not the proof of the absence, in the sense that some patients can be unresponsive yet conscious, simply because maybe they have a damage to the motor output systems. Then there is a second layer where you can assess consciousness. This is called the volitional activation or active paradigms. It's a way to bypass motor blockages. Here you present subject with commands. Imagine to do this or that, play tennis, imagine to squeeze your hand, and you measure brain activity. Very interesting. So sometimes you can discover patients who are responding to these willful modulations, brain modulation. They're called cognitive motor dissociations. It's a quite effective paradigm, very interesting. There's a recent review on New England Journal of Medicine. But again, you can have false negatives because this engages a lot cognitive functions. There's a lot of load on cognitive executive function abilities that are not always preserved. So patients can be negative also at this level. So then the next level is about, relying less on executive function, presenting subject with stimuli, sensory stimuli, and then looking at the cortical responses. And some responses are indicative of the presence of a conscious processing elaboration. For example, the P3B or the local global paradigm is effective in the sense that when it is present, this kind of processing, when you can record this wave, patient is there, so it's quite specific, but sensitivity is very low. Again, because many reasons, it requires a little bit of cognitive effort, but especially it requires sensory inputs and sensory processing, which can be impaired in patients. So, last resort, the final level is, you have to deal with the brain that is disconnected. It's a physical object, and this is the real challenge. Here, you have to point a radar on the brain and kind of extract some physical dynamics or processes that are important for consciousness. It's a challenge, of course. It's a challenge that is not, just an exercise or a philosophical experiment, because you can have these situations of brains that are active but disconnected on the input and output side, especially after intensive, care medicine, which is becoming more and more proficient. Frontal lesions, language network lesions, brainstem lesion, in different combination can lead to this situation. And then, for this reason, you need to develop ways of probing the brain and the thalamocortical system directly by passing sensory input, motor output, without engaging the subject. So this is the kind of story, the way of introducing TMSEG to you. TMSEG is a way of assessing the internal dialogue of the thalamocortical system, specifically the complexity of this dialogue, based on theoretical premises, some empirical agreement, because there's agreement that internal complexity is relevant for consciousness, and the way we do with TMSEG is to perturb the cortex, record from the EEG, so we perturb non-invasively, of course, we record non-invasively from EEG, and then we zip the response to measure the complexity of these interactions. The way it looks, and we are still extracranial, of course, here, is, you have a stimulator on top of the head, you have navigation systems that are, best case scenario, neurosurgical grade navigation. And then, this is very important, and you can appreciate that as neurophysiologists, you can see stuff online. So on the screen, you see the response of the brain. And you can already judge when you look at the screen without powerful or sophisticated statistical tools. So for example, this is, by the way, a beautiful reconstruction that gives the idea of what TMSEG does. This is source modeling of TMSEG done in Boston by Brian Adlow. He's an intensivist now using this system. And you will see, activations that are, of course, source modeling, and then the traces that are presumably active, during this activation patterns. Again, extracranially. all the assumptions of source modeling here. But you see recurrent waves of activation here and there. So what we know is that when you perturb the brain of somebody who's awake and conscious, you have these complex responses that are different lectures recording different patterns at different times. Source modeling of these responses reveals interactions that are widespread, complicated between different areas. If you fall asleep or you fall anesthetized, general anesthesia, you have responses that are becoming simpler, positive, negative, maybe bigger, but really simpler, with source modeling showing a center of mass that is pretty local and stereotypical. You see this on the screen, okay? I'll show you examples in patients as well. This is pretty clear. This has been validated in different conditions, so we wanted to make sure that this kind of complexity is there whenever subjects are conscious, even when they're dreaming, even when they are conscious but brain injured, or hallucinating under ketamine, let's say, all these red cases in the red box. And then, as a counterfactual, we wanted to test whether complexity is gone in conditions where consciousness is diminished, at least. So anesthesia, deep non-REM sleep. And then, based on this calibration, we calibrated this index of complexity on benchmark data, conscious, unconscious. We derived an operational cutoff. It's just an operational cutoff that we use to say, well, if you're above that cutoff, that is, if you are in the range of complexity that we normally see in people who are conscious, well, even if you are unresponsive patient, we question the clinical diagnosis. So what happens in terms of sensitivity is minimally conscious patients who are minimally conscious, minimal fluctuating signs of consciousness, they are mostly high complexity, so 94%, meaning there's a high sensitivity here, which goes beyond the sensitivity of spontaneous EEG. So by perturbing the brain and measuring complexity, you gain a little bit. You can find high complexity MCS patient who has a severely abnormal EEG. But the interesting thing is what happens in unresponsive patients. Here is where you make the inference based on the calibration. And what we see here is that many of them are in the low complexity range, showing responses that are very similar to those that we observe in sleep, positive, negative wave. Here's an example. So this patient has a diagnosis of a vegetative state or unresponsive wakefulness syndrome. So eyes are open, patient completely unresponsive. TMS EEG performed by our colleague Mario Rosanova here in the Gnocchi Institution, where we work a lot. It's a subacute rehabilitation center. Navigation, and then you can appreciate on the screen what happens, and you can maybe compare the wave shape to the wave shape on the left. If I'm skilled enough to stop it at the right moment. Okay, so you see here, positive, negative wave, way more similar to this one than this one. That is low complexity response, already on the screen. So this is consistent with the clinical diagnosis. But also, we find patients who are unresponsive but high complexity with this kind of complex recurrence wave of activity. They score high complexity, perturbation complexity index, about 20% of them. Here's an example. This is a dramatic example of midbrain cerebellar injury, intensive care setting in this case. The patient is unresponsive, eyes open. They look for everything like vertical eye movements. Is it locked in? Or decisions are based on, it's very delicate to take decisions in these cases. So the patient is sent to our center for a TMS EEG evaluation, intubated. Now you see. So the patient is totally unresponsive, completely unresponsive. But then you can look and appreciate what happens on the screen online already. So this is a different response. This is way more similar to this one. And already on the screen, you can see that there is something going on, recurrent waves of activity in the thalamocortical system leading to high complexity. And indeed, the patient recovered vertical eye movements, suggesting that he was actually logged in at the time of the measurement 2 weeks later. And this is one example out of many. This is just to say that, there's also room for this intensive care medicine where decisions are taken and all these things. But here, mechanism. So what are these waves? Why do they fade? And, what do they mean? So here, when you fall asleep, and this is again extracranial, you see that you have recurrent wave activity in wakefulness, and they become simpler until they develop into this positive, negative wave. So what we know from intracranial work, this was done early on by also Andrea in collaboration with people in Wisconsin, is that these recurrent waves of activity, they reflect feedback. So reentrant activity, corticocortical, maybe corticothalamo-cortical activity, and when you fall asleep, everything becomes feed-forward, and these recurrent waves are gone. So they reflect feedback in the system. This has been recently confirmed by modeling. I think Davide Momi is here, and he's going to present something at some point, going deeper in that. So there is evidence that you have these recurrent waves. Furthermore, this is interesting. Simone Russo is also here. He has, a paper, I think it's accepted now in Nature Communication, where combining extracranial, TMS-EEG, intracranial stimulation and recordings, Niguarda, rodents, Allen Institute in Seattle, and modeling, shows that the later waves after a direct cortical perturbation are also contributed for strongly by the thalamus. So we have corticocortical, corticothalamo-cortical connectivity in one shot. And this is interesting, and I think it connects to a poster that Josef Parvizi will present later on. And it's interesting for different reasons. First, one shot cortical stimulation, you ping the brain and you can appreciate, and it's a very practical way to appreciate feedback in the brain, to perturb and see what comes back. So it's a very natural way of doing it. And those feedbacks are corticocortical, corticothalamo-cortical. This is relevant because, for example, thalamic stimulation is relevant to restore consciousness in patients. It's one of the manipulation, the kind of work, at least this is a work intracranial in monkeys, because patients recover, as they recover, actually before they recover consciousness, they recover this recurrent wave of activity that are probably corticocortical and corticothalamo-cortical, and that we can read out. Finally, it's relevant because, among the different theories, there are different views on consciousness, it's a hot debate, but actually they all agree that reentrant feedback, corticocortical, corticothalamo-cortical, are important. So this is also common ground in theory. I open a parenthesis, so intracranial, they contribute to understanding these things, and I'm talking about global changes in the state of consciousness, but also they're relevant for understanding the neural correlates concept perception. I just want to open a parenthesis here to point out that there's going to be very interesting talk here. I was going through the program, so there is Andrea's talk, super interesting, 3-modal stimulation, extent of cortical activation, and much more on Thursday. Okay, back to states of consciousness. What happens in patients who are stuck into this low complexity sleep-like pattern? Question is interesting because some of them recover, some of them don't. So what is it under this positive, negative wave? So here we go back to sleep because in sleep we see the same wave. And in sleep, nobody is cutting synapses or disrupting brain tracts. So there must be some mechanism responsible for this disruption of corticocortical or corticothalamo-cortical interactions and this very simple pattern of activation. So sticking to the cortex, what seems to be relevant, what could be relevant, is this mechanism that I mentioned before, bistability. That is, the tendency of cortical neurons to plunge into a silent period after an initial activation. This is this is the basic mechanism of sleep, slow waves. It happens when we fall asleep. It happens because neurons are increasing activity-dependent currents, so the more they become active, the more they are shut down by potassium activity, or because inhibition is increased. All this depends on decrease in the firing of activating systems. So under these conditions, neurons are changing their behavior dramatically. And I think in a nutshell, this movie that I got from a recording from Igor Timov in Canada is very, telling, because you see here, like, okay, wake, you have this nice low amplitude, high frequency EEG, and the discharge in neurons is tonic, and the membrane potential is super stable. And they can sustain increase of activity without going down. But as soon as you fall into non-REM sleep, things are very different. So here, neurons are becoming active, and then they shut down. And every time they shut down, they become hyperpolarized. They do so synchronously, and you see a slow wave in the EEG. So chances are that these slow waves, actually we hypothesize these slow waves triggered by TMS is the result of the fact that neurons are activated, activities start to spread, but then neurons are becoming bistable, they cannot sustain activation, they shut down, and everything dies. Complexity dies because of that. So this was the hypothesis. Intracranial data are very useful here because they show that we can detect these off periods also by looking at the LFP, so by looking at not necessarily units, but you can detect them by looking at high frequency suppression in the LFP. This is beautiful work by Sidney Cash. And so, you know, with Andrea, quite a few years ago, almost 10 years ago, we started reasoning on that and say, okay, maybe we can study the effect of cortical stimulation across stages with, you know, intracortical electrical stimulation and LFP recordings, and then try to connect that to the global scale EEG thing. And it's an interesting proposal. I have to say that intracranial stimulation can be a model for what we observe with TMS-EEG with some caveats. And there's going to be a poster about the direct comparison between the effects of TMS and the effect of intracranial electrical stimulation. They're kind of similar, like they share similarities, but intracranial is way more powerful. We need to account for that. I mean, 10 times. The response to intracranial is 10 times bigger, but still, they change in a way that is consistent across brain states. This is work in progress, actually, under revision and a poster that you will see. So, you know, intracranial is a good proxy, a good way of, you know, at least capturing what happens when brain states are changing. And in this sense, I want to show you, you know, intracranial stimulation, source modeling with high-density EEG. So this is the wake response to an intracranial perturbation. And this is the sleep response. So again, you see the collapse of a complex pattern of cortical activation. Most importantly, the observation is that when you look at, you know, you stimulate here and you record intracranially with stereo EEG from another place that is connected to the site of stimulation, you see a response made of recurrent waves of activity during wakefulness, as you do with TMS-EEG, and then this slow wave response in intracranial recordings. But then in intracranial recordings, you can easily spot the downstate, the suppression of firing, because you can perform time frequency decomposition and look at high frequency suppression, which you clearly see during sleep. So the receiver, if you stimulate here, the receiver there becomes active initially, and then the neurons are shutting down, and then they recover activity later on. So there is this interruption of firing. And the key finding here is that this interruption of firing, presumably a neuronal downstate, has profound consequence on the chain of, you know, cortico-cortical interactions, because these cortico-cortical interactions are sustained during wakefulness for several hundred milliseconds. Phase locking factor is a way to measure that. Whereas in sleep, after the downstate, you have resumption of firing, and then everything dies in terms of causality. So what happens basically is that neurons are receiving, becoming active, they hush, become silent, and then they resume activity stochastically. They basically forget the input. This is a killer for building up changes of causal interactions and complexity, and actually it's a killer for feedback interaction. So in a sense, this downstate stochastic reboot is actually a killer for integration complexity in the system. So it's nice because it relates one process, neuronal process that we know very well in all the details, we can study that in vitro as well, to a global thing. And indeed, during the Human Brain Project, and again, I have to thank Andrea once more here, he was, you know, pivotal in organizing together with Pietro this multi-scale exploration of the same thing. So again, intracranial as a bridging principle, TMS-EEG from the outside, intracranial, rodents, slices, and in silico simulations, where perturbation and recording always show that whenever you have loss of complexity, or actually whenever you do manipulations that are bringing into sleep anesthesia, or you simulate, you know, anesthesia, you have downstates occurring in neurons, breakdown of cortico-cortical interactions, and loss of complexity. So this is a multi-scale exploration. that cycles back to the clinic. Because then, once you understand this, you become curious and you want to know, so can we see downstates or bistability in vegetative state patients, unresponsive wakefulness syndrome patients, which actually we tried to do, building up on the experience of, gained in intracranial recordings. And so this is a subject who's healthy, awake. We go back to TMS-EEG. So no downstate, recurrent waves activity, sleep. You see up, down, suppression of high frequency. So this is, consistent with what we saw intracranially. And then the question, what about vegetative state patient or unresponsive wakefulness state patient who are eyes open? And what you see is precisely the same thing you would see in somebody who's sleeping with eyes closed. So it's an intrusion of cortical bistability in a subject whose eyes open. The brainstem presumably is working, but something is wrong in the thalamocortical system, and there is this widespread sleep-like response in this brain. It's interesting that this state of affair can evolve. So this is a patient who starts vegetative state, low complexity, downstate, short, lasting causality, and then gradually, the downstate fades and everything, comes back to a pattern of integrated and complex interactions. So there is room for reversibility. We just don't know why this happens. But it's, it's crucial to understand, what are determinants of this. And in vegetative, by the way, this was replicated, interestingly, recently by intracranial stimulation recordings in patients, group in New York, CIMA, Boca Famenta. And so in the vegetative state patient, this intrusion of bistability, sleep-like bistability is everywhere. Wherever you stimulate, wherever you have an island of cortex, you see these slow waves and suppression of neuronal activity, speaking for bistability. But it's interesting that recently, simultaneously with another group in Germany, we observed the same thing in the perilesional area of a stroke. This time around, bistability and sleep-like responses are local, leading to a local loss of complexity. They don't entail the whole brain. Patient is conscious, by the way. But you have an intrusion of the same mechanism around a lesion. And we know that sleep and wakefulness can coexist. Lino Nobili will give us, beautiful examples of this. But why should sleep intrude into wakefulness after brain injury? It's an open question. We have some ideas. So why does bistability after brain injury in somebody who's awake, eyes open, with the activating system in working order? So one possibility is that you have actually, precisely, either a damage to the activating system or a damage to the fibers ascending from the activating system to the cortex, or maybe diffuse axonal injury, breaking the axons, bringing up the neuromodulation cocktail that keeps the cortex awake. So that part of the cortex is going to fall asleep. Another possibility, non mutually exclusive, is that you have damage to lateral fibers, either short range, because you have a cortical injury leading to short range disconnection, or long range, or again, diffuse axonal injury. What happens in this case is that excitation drops. You have disfacilitation, because long range is normally excitatory. Local inhibition prevails. It's an increase in inhibition. So in this case, you would have increase of adaptation, that is potassium currents that are activity dependent, the classic effect of low neuromodulation. In this case, you have increased inhibition. They both concur in leading to, these sleep-like downstates. Actually, whenever you disconnect the cortex from the rest, you have downstates in slices, in cortical slabs, in cortical gyri, in hemispherotomy. With Niguarda, we recently, performed the study in hemispherotomy. And what does the, isolated hemisphere do once you remove epileptic activity? Sleep. Sleep. Slow waves. Big slow waves. Bistability. Like a big slice. And this after brain injury can happen in also very subtle manners. So, for example, this is a subcortical injury, pretty small, far from the cortex. You do disconnectomics, so you recover the tracts that are affected by the lesion. You project the disconnectomies on the cortex, so you know which cortical area is presumably more disconnected. And then you target this area, you put it on the navigator, and you target with TMS this area together with other areas. This is work by Simone Sarasso, Sasha D'Ambrosio, it's beautiful work. And what happens here is that if you target areas that are not disconnected, you have recurrent waves of activity, complex responses, again, the other side. But if you go on that area that is structurally intact, but just, disconnected based on disconnectomic, the response is sleep-like. So even far away, it's not only the perilesional area, but whatever get disconnected, go into a sleep-like reactivity pattern with consequences on information processing and local circuit complexity. So disconnection can lead you to sleep in critical ways, but also inflammation. We know injecting TNF alpha or interleukin can lead to increased slow waves in the cortex, and also ischemia and hypoperfusion. There are potassium currents depending on ADP. So there are many concurrent factors leading to the intrusion of sleep after brain injury. And then the intrusion of sleep after brain injury by stability has a consequence on the network. So this is a thing that we need to account for. And it's interesting because once you have this intrusion, let's say you have a cortical, subcortical injury leading to lateral disconnection, disconnection from activated system, and for many reasons, maybe because also inflammation, you have slow waves here. Most of you are familiar with the propagation of epilepsy. Slow waves can propagate. Even these sleep-like slow waves. They do so when we sleep, during sleep. And the question is, they do so, this is work by Yuval, is here, also intracranial, beautiful work showing the propagation of slow waves. And the question is, do they propagate also post-lesional brain injury slow waves, perilesional? Can they propagate and interfere maybe with activity far away in the network? So this is where, again, intracranial comes in with a key finding by Simone Russo, again, who's here. And here we explored it together with Niguarda, Ivana, whom I don't mention, intracranial lesions, radiofrequency thermocoagulation, and you see here what happens. So here you have before and after. So after, you have slow waves with a gradient. Prominent, close to lesion, decaying, about 1.5, 2 centimeters slow waves, developing after the lesion. And then you have that areas that are connected specifically to the perilesional area, and we know they're connected because we use cortical evoked potentials, they go into a slow wave regime. Actually, they increase their delta. So as if the interference is projected onto a network. So this is actually resonating with the old concept of diaschisis, the network effect. Again, there will be more about this later on Wednesday. Also, there is a poster about the effects of this on effective connectivity, network disruption. So now, putting it all together, we try to do so, preliminary in this review. The idea is that you have this intrusion of sleep, slow waves because of disconnection, ascending, lateral inflammation, or ischemia. They are disrupting the area surrounding the lesion, which is already a problem, but they also propagate in a network, level, and they can have behavioral effect. Why do we say that? Well, because every time slow waves are intruding into wakefulness after sleep deprivation, they do have a behavioral effect. They're causing impairment. They do so in rats. If you have a slow wave in the left motor cortex, in that very moment, the rodent is unable to reach a palate. You can have it at the cognitive level. Andrion, Thomas, beautiful work. And again, Yuval, intracranial, showing that when you have slowing, intrusion of slowing, you have, again, lapses, cognitive lapses. So there are chances that, this can have behavioral effects. Again, Yuval will present about, the relationship between sleep slow waves and general sleep patterns and cognition. So, for example, you might have a case where you have an intrusion of slow waves in the right side of the brain and because of a lesion, and then maybe that contributes to neglect. Who knows? Well, we're testing this with our team in Milan, Elisabetta Litterio, Elena Focacci, and Madalena Bucur. This is a patient with neglect. I'm almost done. How am I doing? Andrea, am I super late?
I'm not taking the time.
Okay. Good. No. Okay. No, I'm almost done. Okay. Oh, okay. Right. So this idea, for example, that neglect. Yes, we have a lesion in the right side of the brain, but there's more than that. There is slow wave propagating. Maybe part of the hemisphere is falling asleep as you're awake, and this is obviously, having an effect on this, for example, attentional bias. So this is an interesting study, super pilot experiment. I just want to share with you because, we are here to share interesting things. So the patient is wearing an EEG cap, looking at this starry night kind of, pattern, and he's asked to explore. Just explore, because sooner or later something is going to blink. But we are interested in the exploration part. 15 seconds of exploration every trial. And we know where the patient is looking at every time. So most of the time to the right, sometimes to the left because of neglect. And now the idea is that, okay, maybe the fact that this attentional bias, the fact that it's way more to the right is due to, slow waves in the right side. So this kind of unilateral, kind of dolphin falling asleep of the right hemisphere. So we don't know. We're looking at the data. There are strong indications that this might be the case. So actually there's a relationship between the attentional bias, very strong, for example, in this case, and better in this case, and the amount of slow waves. So the more slow waves you have, the more the patient is stuck to the right. And in the moments that slow waves are released, even on the short term, the patient is able to go to the left. So this is a very interesting piece of information, and potentially interesting for understanding the consequences of brain injury and maybe developing some kind of new treatment by modulating somehow slow waves. But that's one side of the story. Slow wave, they do have behavioral effect, but they also might have protective role. And I think you're going to hear about this on Wednesday when Laurent, presenting something very similar, happening, in a way more relevant field for you, that is epilepsy. So slow waves around the focus are, correct me if I'm wrong, they do have behavioral effects, but they also might have a protective role. So it's the same, kind of two-phase, flip of the coin thing. So we don't know, actually, and especially after brain injury, it's a hard call whether you want to decrease slow waves or increase slow waves, because their protective role is important. We know that they save energy, they are good for cleaning up the extracellular space, it seems. They are definitely related to learning, homeostatic processes in the circuit, and axonal sprouting. So maybe you want to let them go around the lesion in the acute phase where you need them, and maybe you want to stop them later on in the chronic phase, far away, if they interfere and disrupt with normal activity regimes. We don't know. We need to study this. So that's why we have a grant that is a synergy grant with Maurizio, Mavi Sanchez, she's an expert of cellular sleep, and Gustavo Deco, who's an expert in modeling, and we'll try to sort out, understand a little bit more about this. But what I want to say here is that it's a celebration of intracranial stuff, and I hope I convinced you that this trajectory was primarily driven from this insight. Also, a celebration of neurophysiology and history. Many things have been said already. So I always like to say this, that we need to read papers, the old papers. So diaschisis concept, very good concept. It's an incredible idea based on clinical facts from Monakov more than 100 years ago. The network effect, the disruption, way beyond the lesion of activity, and then neurophysiology, because actually the intrusion of slow waves after focal brain injury was already described very clearly by by one of the fathers of EEG, William Gray Walter. And actually, I was surprised to learn, as a sort of sleep expert, that delta rhythm was named after the perilesional slow waves. I didn't know that. I thought it was like, discovered during sleep. Actually, they were discovered in the perilesional era of a tumor and then called delta because of that. So it's good to look back always. And so looking forward, actually, to this meeting, thanking all the people. I couldn't put all the names on my lab. I have to do a new slides, but it's going to be super crowded. I will do it better. This is not even the right picture, so there are many more here. But especially I want to thank Niguarda. Lino is not in Niguarda anymore, but he's been fundamental in all this. Ivana and all the people there, beautiful. Dognocchi is another place where we work a lot together, and then the collaboration about coma in Liège, Wisconsin, Boston, Massachusetts General Hospital, Padova, Barcelona, and finally Parma, Pietro, and Maria. Thank you. Thank you.
I already knew the story, but actually every time I listen to that is impressive. Thank you very much. If we have time for a couple of questions.
Thank you for this great talk. I have about 125 questions, so I just limit to one. Your hypothesis is that these slow wave you elicit with TMS are the same than slow wave we see during sleep, something likely to. Have you seen or do you expect them to change in the same way that sleep slow wave change? For example, would they increase in amplitude after sleep deprivation, or can you see such modulations?
Yeah, beautiful. Thank you. It's one of the 100 questions, but this is great. So, yes, I think that the underlying mechanism, so when we do TMS-EEG and we do it during sleep, we see this positive, negative, and suppression. In the vegetative state patient, we see the same. In the stroke patient, we see the same, more local. I think that that this is a common mechanism at the neuronal level, but I think they are different somehow from the sleep slow waves. So first of all, these are evoked slow waves, right? So the one we observe with TMS is a great way to probe, I think, activity-dependent mechanisms, because you're challenging the circuit by increasing activity and you reveal either inhibition or too much adaptation mechanism. That's what we see, and this is where I would push the similarity. Adaptation or too much inhibition, then a slow wave. And then the real question is, what you're asking actually is, are they homeostatically regulated? Are they really sleep-like slow wave in the sense of their function, their dynamic? Do they decay or obey the same rules? We don't know. This is a great question. So I think sleep-like goes as far as they share similar cellular mechanisms. They have similar disruptive effect on the network, leading to this chain of detrimental effect to network activity. But in terms of their function, I don't know, and a lot of research needs to be done there, including maybe also sleep recordings after brain injury. But I would be curious to discuss this with you more.
Any other question? Lino. At the phone call.
Thank you, Marcello. Fantastic, always. As a dirty clinician, so what do you think, how to manage with these slow waves? This is a question we sometimes discuss together. Sometimes probably these slow waves are adaptive, so are reducing some inflammation and then become maladaptive. Do you have anything in mind regarding how can we disentangle between the ones that are good, the ones that are not, or when they become really maladaptive. So, and how can we modulate that?
Yeah, so this is actually the challenge, and this is the core business of this, effort, this project that we have that is called Synergy. I think longitudinal measurements are going to be very important. So studying, for example, after stroke, slow waves or evoked slow waves or spontaneous slow waves right after injury, and then see whether they can predict outcome in some way, like either positive or negative. And then also study, so in space and time. So one hypothesis is that in space and time, early on, close to the lesion, they might be useful. So longitudinal measurements, and then, later on, demonstrating that they are detrimental, far away, and, in the more chronic phase. I think that as far as, once we have, so for now it's an association. You have the slow wave, you have the lesion, you have the impairment, you have a mechanism. But we need to put it all together in a causal chain. So demonstrating, for example, that slow waves, if I have a slow wave now here, post-lesional, I do have an impairment, that would be already great. And then the way we would do is, actually as a proof of principle, is to dampen the slow wave, neuromodulation, anti-phase stimulation, transcranial, even transcranial stimulation, and reduce the slow wave there temporarily and see whether they improve. You have a temporary behavior improvement, and then you start working on that. The underlying idea is that we don't want to do the magic. We are not, we don't want to fix the circuit. But the idea is that if you get rid of, pieces of brain that are falling asleep and offline during rehabilitation, that's a good thing, provided that, you don't disrupt the protective part of it. All this neuromodulation work builds up on intracellular slice work by Mavi, and then it's going to be translated in rodent model and then human. It's a long way. It's a long way.
Thank you very much. I have a question about post-cardiac arrest patients because there is all this need for neuroprognostication, we say, after cardiac arrest, and it relies on analysis and on EEG. And they see that according to different EEG patterns, for example, generalized periodic discharges are a very bad prognostic factor, whether instead, like for example, epilepsy or status epilepticus are actually related to a better prognosis. Do you have any insight on, because like post-cardiac arrest, they're not focal lesions usually, they are more generalized. So how different then these different EEG patterns actually reflect probably what is going on inside?
Yeah, very challenging population, of course, and it's an important question. So also bilateral somatosensory evoked potentials are a negative prognostic factor, super reliable when they're absent, but then, so we need better, prognostic factor, that's for sure. And, I think the analogy with somatosensory evoked potential is useful in the sense that maybe TMS-EG, whenever positive, so it could kind of complement somatosensory evoked potential, because TMS-EG is going to be often negative in these patients simply because the cortex is severely damaged. So it's very difficult to find an entry port and stimulate the brain. But if positive, and we have examples of that, also in Boston, they are actually working in the ICU and they find example of that. If positive, it's a positive prognostic factor. So in this sense, if you combine the SEP on one side, TMS-EG on the other side, you can at least gain a little bit of negative and positive predictive value. Yeah.
Any other question? So thank you again, Marcello.
Thank you.
And with respect to the program, we anticipated the coffee break. So in the room over there, we have, you can find coffee and something to eat. In a half an hour, we'll be back with the roundtable and with the final keynote lecture.
Valerio, facciamo una prova di presentazione. Valerio, can you project this? Ah, we see it here. Okay, it works.
Okay. So without any more hesitation, we restart with the session of the afternoon with a roundtable that we specifically designed to let all of you, I know that most of you already got in contact with the stereo EEG, but letting all of you getting familiar with some of the definitions, some of the context regarding stereo EEG. And this will happen throughout this roundtable titled The 7 W's of Intracranial Electroencephalography, a title that probably amazed many people, not really understanding, but the point is that the 7 W's are just the 7 pronouns, who, what, which, where, and so on, that basically allow us to track some IED, some features, some characteristics of intracranial electroencephalography. And so the aim is to, again, introduce you to the core principles, the clinical relevance, and scientific potential of stereo EEG. And in this journey, in this aim, we have the privilege of having with us 3 delightful guests. The first is Giorgio LoRusso, who for many and many years directed the Claudio Munari Center in Niguarda, and so basically has vigilated, I'd say, on our research for a very long time. He insisted a lot for being here with us. And the second one is Fabrice Bartolomei from the University of Marseille, representing one of the epileptologists most representative of the school French. We should have had Jorge Gonzalez Martinez from the University of Pittsburgh, who had accepted and who probably will join us tomorrow. But unfortunately, he got into some flight struggles, I'd say. And so a double thank you goes to Florian Morman from the University of Bonn, who is here not for playing Jorge's role, but just for contributing also his angle on the very same questions that we designed. So the tone will be very conversational, but before starting with the individual features of stereo EEG, the relevant part is to give some definition. And given that we advocated for some synergy between research and clinic, I needed to have a clinical partner in crime. So here I have not Francesco, but Chico Cardinale, that will not only join me in making questions to our guests, but that will also give us some initial definition to start from about stereo EEG. Chico.
Thank you so much, Pietro. Thank you, everyone, for starting and launching this roundtable. And just 20 seconds. I guess that everybody in the room knows what ECG is, but I would like to give a very pragmatical definition of ECG. That is a method aimed at defining the three-dimensionality of the epileptogenic zone by means of an adequate number of intracerebral electrodes. Just one picture, one slide with an old traditional schema after intracerebral electrodes were implanted according to the rules given by the school where ECG was born. And more modern images, the concept remains the same, many intracerebral electrodes implanted in the brain. Technical tools are much more modern and possibly informative. But I don't want to spend anything more about this, and I give again the word to Pietro to start with our 7 W's.
Yes. Yes, so let's start from the what. So let's start from a very basic definition. Chico told us what stereo EEG is or can be defined. So Giorgio, basically, what was stereo EEG at its dawn, at its origin? and what distinguishes, in principle, stereo EEG from other neurophysiological methods in the clinical setting?
Okay, thank you, Pietro. We can say that at the beginning, the stereo EEG, well, actually, it was not yet called stereo EEG, of course. The name comes many years later. We can say that was an attempt. I have my note to read it, so to respond to the needs of those who wanted to treat surgically epileptic patient, but they were not fully convinced, not fully happy with the methodology that was utilized till then. That was the methodology of Penfield, of course. So looking for interictal spike on the surface of the brain with stimulation of the cortex, so to allow to reproduce signs and symptoms of seizure, strictly in an interictal environment. So those pioneers of the epilepsy surgery thought that the brain was a kind of 3D environment. A 3D environment, and the seizure was a persistic activity spreading into the 3D environment of the brain, and signs and symptoms comes from the activation of each region of the brain by means of the epileptic discharge. So they thought that an approach was needed that needed to explore in the 3D the brain and have a system to record the spontaneous seizure of the patient and the spatio-temporal dynamic of the evolution of the discharge. Talairach and Banco shared this concept, and they found themselves working together. So on one hand, we have the neurosurgeon. They start to imagine how to reconstruct the stereo, the 3D environment of the brain. On the other hand, the neurologist that studied the localization of the brain and the evolution of the discharge. So the genius of those two put together give rise to the stereo EEG that we know today and that we use now in the same way with the same principle, even with the knowledge and the advantage of the new technologies.
Okay, thank you, Giorgio. Thank you, Giorgio. Now I would like to ask Fabrice, what's the role of stereo EEG in understanding complex epileptic networks?
Are you sure that I will answer to this question?
Saving our evening on the pub.
Okay. Of course, if you look at the term of your question, there is a different term. The first is understanding. I'm not sure that we always understand the complexity of the network when we explore patients with SEG for many reasons. And one of these reasons, of course, is the sampling problem, which is central, I think. But I would say that if I start from what Giorgio said, is that when we start to do SEG, we replaced a method that was a ECOG and all these also grids. We claimed during many years that SEG was superior to grids because of the 3D vision of the brain, of course. And the idea of networks is really linked to the SEG, I think, because it started from the observation of different structure, distributed structure in the brain that could be reached by our electrodes. That was impossible with grids, and it was before the areas of neuroimaging. So for long, since the beginning, if you look at the first scheme of Banco and Talleyrand, you see that you have this different structure in the brain where you see the start of the epileptic activity and the distribution in different structures. And after accumulating the observation, what we have seen is that the seizures start in a given part of the brain, propagate in a given part of the brain with very strong, I would say, reproducibility. And that's the first characteristic. It's very highly reproducible. Often people think that the epilepsy is a disorder of electricity in the brain. No, it's a very structural phenomenon with high reproducibility. The second point is that this change occurs in system in the brain. It's not organized by change. It follows system in the brain. For example, mesial temporal limbic system, visual system. And you can follow the system by just following the trajectory of this seizure in the brain. That's an information that was very easily to observe when we have enough electrodes in this region. And the third characteristic, I would say, is the role of the lesion. Initially, the SEG was designed to explore brain lesion because of the absence of scanner, of imaging, and particularly tumors. And I listened with interest the talk about the slow wave. And one of the first objectives of SEG was to detect slow waves associated with tumors to guide the surgery before the area of neuroimaging. And when we look at the behavior of some lesions, you see that these lesions are not always the seat of the focus, and you can have more complex organization. So I think just by these few descriptions, SEG was essential to the description of the network. And of course, with the development of digitalized EEG, we could study functional connectivity, more complex methods. But fundamentally, the idea is to look at the behavior of different regions in the brain with this 3D approach.
Okay, thank you, Fabrice. Despite the fact that SEG now is quite spreadly diffused, I think that it's quite new for many centers. So, Florian, up to you. What's the biggest misconception that many people can still have about SEG?
Yeah, so since I only learned today that I would be sitting here as a replacement for Jorge Gonzalez Martinez, I think I'm afraid I will need to twist some of the questions in such a way that I feel I can give a meaningful answer. And for this one, I think I'm not even sure if I would call it a misconception, but there are different conceptions as to what types of intracranial electrodes are how invasive. And this kind of goes to comparing what I guess one could call the traditional US school versus the, I'll say French school, French-Italian school of stereo EEG. And traditionally in the US, I guess Spencer was one of the pioneers there. The view was that sticking something into the brain is rather invasive and that one should avoid it if possible. And that an alternative could be to use subdural electrode, which do not penetrate the brain but are still under the skull bone, those electrodes might be able to do the same job less invasively. And so I come from a center in Bonn, Germany, where for decades we followed the Spencer/Yale approach. I'll quickly describe it to give maybe an example. So we would typically have in medial temporal lobe epilepsies, where very often the hippocampus is the focus causing the seizures. The hippocampus is very well shielded from the outside, from the surface of the brain, because it's curved in like this. And hippocampal electrographic signals are very difficult to pick up from the scalp. So that was considered something inevitable. So we would have one electrode along the longitudinal axis of the hippocampus, kind of like this. and both on each side, so 2 depth electrodes. And in addition, we would have 3 subdural strip electrodes on each side, 2 temporal basal one and 1 temporal lateral one. The latter 3 all through the same burr hole, so it was only 2 holes. And the idea was that that was less invasive than, for example, poking, I don't know, 4 electrodes in orthogonally. And we have changed to this latter scenario 15 years ago. I was also a relevant factor in creating this change. And the facts that are present are that in terms of complication risks, there is no difference. Please correct me if I'm wrong. As far as I know the literature, in terms of the complication risk, there is no difference between the depth electrodes or the subdural electrodes. The important thing for the depth electrodes is that the neurosurgeon realizes where there are blood vessels and makes sure to avoid them. That is the key for safety with depth electrodes. Whether there is any cognitive damage or deficit, I believe is not entirely clear. There is a very old and not well-known study from my center in Bonn, where our neuropsychologists described the cognitive outcome after resection of the hippocampus. And they found that the cognitive outcome was significantly impaired if the contralateral, meaning the healthy hemisphere, had been implanted with a longitudinal depth electrodes. So what we can defer from that is depth electrodes are not necessarily harmless in terms of cognitive damage, but one reason why we still do it, and even do it more now than before, is if you think about what it is you're implanting, and especially if you consider the structure, the architecture of the hippocampus, which is very segmental, and every segment features what is called the trisynaptic pathway. If you go through it longitudinally, then you can basically destroy one of the areas, such as CA1, completely, or do a lot of damage. And that could easily result in impaired function. Whereas if you go in from the side, even with 2 or 3 electrodes, you will likely hit or damage a few of these segments, but the rest should be preserved. Which is why, for me, the reason why I felt comfortable suggesting that we change from longitudinal to orthogonal was that it makes a lot of sense that these are less harmful. And if I were a patient, I would prefer the scenario that we have now. Having said that, it took me years to convince our neuropsychologists to finally redo this study with our current patients, and I don't know yet if this hypothesis will be verified or not. So I think in terms of cognitive impairment, there might be a slight disadvantage of the depth electrodes. I think it's not entirely clear at this point. The third aspect I would like to discuss is pain for the patients. And there we see a huge advantage of the depth electrodes because the brain parenchyma, the brain tissue itself, is not pain sensitive at all, which means if you stick an electrode into it, the brain will not feel any pain. The dura, however, is incredibly pain sensitive, and when you have subdural strips, then you have a 12 millimeter burr hole, and then you sort of push them in there, and all the while they scratch along the dura. And I've seen patients with 12 or more depth electrodes who on the day or basically when they awoke from the anesthesia, they were fine. They hardly needed any pain medication, whereas typically if you have these subdural strip electrodes, patients are in miserable pain and often need very strong painkillers. Again, you could argue, okay, they have to go suffer through that for 2 weeks as long as they don't have any permanent cognitive damage. But I think at the end of the day, these are aspects that need to be weighed against one another. So I personally share the idea that it's a misconception to think that subdural electrodes are less invasive.
Okay. Thank you so much, Florian. So the first W has done. Now we'll learn about the 6 remains Ws in the next 4 hours. So, Giorgio, where has SEG grown and developed?
Well, I don't want to contribute to the next 4 hours, but just to start. Okay? Of course, where steerage has grown in Paris, ça va sans dire, say our French friend, and particularly from the Sainte-Anne Hospital, where Talleyrand and Banco worked. But even if I have the honor of referring to this source, to this group, I have to say that even for steerage, the Montreal Neurological Institute has somehow is involved. Why? Because in 1952, a neuropsychologist, a Parisian neuropsychologist, Henri Aix, went 1 year to Montreal to study the patient operated on by Walter Penfield. And even if this was not the first goal of his trip, he was very excited, happy with the result of the surgery, of the epilepsy surgery, the result of seizure of the patient of Penfield. And when he went back in Paris, he convinced two neurosurgeons, Mazar and Guillaume, to start a program of epilepsy surgery at the Sainte-Anne Hospital. And so they started, they already operated on some patient with the Penfield method. This program was entrusted to a, let's say, neurosurgeon, Jean Talleyrand. Let's say neurosurgeon because at the beginning he was not at all a neurosurgeon, he was a psychiatrist. But during the war, the World War II, he received some patient, some soldier with a wound in the head. So he had to cure them and become, in some way, a neurosurgeon. But he was not only a neurosurgeon, he was also a cartographer during always the war. He found and he described, draw the picture of the catacomb in Paris. Already at the time, he was keen to draw the knowledge of the space of the endroit French that he was interested in. And he received an award, a medal, military medal, because with this draw of the catacomb, the resistance was able to fight against the Nazi during the war. And he had also an attitude common to some neurologists. He was not at all happy with his neurosurgeon, so he decided to start itself to operate. You used to say psychosurgery. At the time, psychosurgery, epilepsy surgery, more or less were the same things. It's too important to leave to the neurosurgeon. The same as Otfried Förster, you remember, who invented the electrocorticography. He was not at all happy with his neurosurgeon, so he started to operate his patient himself. And apart Jean Talleyrand in 1952, a neurologist from the Salpêtrière came, a neurologist that was interested in cerebral localization and in the concept of the evolution of the discharge to the environment. It was Jean Banco. So the two shared the common goal and started the program of austerity in Sainte-Anne.
Okay, thank you, Giorgio. Florian, partially you have already tackled this question before, but basically, if you have to, given that you experienced both the US domain and the European one, how do you see stereo G in the US, especially in the future, and whether you can foresee a more centralized or a more widespread role of it?
I'm afraid for this question, I cannot answer for the US. I simply lack the experience there. I was there for 3 years, from 2006 through 2009, as a researcher only. I worked with Intracranial in a clinical center, but I never saw patients or was responsible for them. So I can talk about Germany, and I could imagine that it's perhaps not so different in the US. In Germany, the number of centers that implant, and I think all of them these days implant depth electrodes primarily, so the subdural electrodes have almost disappeared in Germany, at least. I can think of at least 6 or 7 centers that are currently doing it. And in my opinion, that is actually a bit of a problem, because that way you have neurosurgeons that will do maybe 3 or 4 cases per year, which I would consider perhaps not enough to really gain a substantial experience. So I think in the interest of the patients, even though their nearest hospital to have such a procedure done would be further away, it would probably be better if it were more centralized, and if those people who continue to do it had a substantial experience doing it, and thereby a better expertise. In Germany, we currently have a hospital reform that was started before our last government broke apart, so no one knows if it's going to be carried out or not, that actually aimed precisely towards that. And my reading of the situation was that no one really from the healthcare system debated that this was a useful measure. The only problem was, of course, that especially in rural areas, patients would have longer time to get to a hospital. But especially with implantations for epilepsy, for invasive seizure diagnostics, those are what we call elective surgeries, meaning they don't have to happen this week, they can also happen next month. Nobody's life actually depends on it. And I think that's all the more a reason why the accessibility of the hospitals should not be a primary concern.
Yeah. Fabrice, we stressed out in the conception of this meeting the interaction between research and clinic. So in your experience, where should we focus more efforts than now to maximize the scientific value of stereo EEG?
I think it's a difficult question. It depends on the, of course, on the centers. But I'd like to just to remind that the SEEG, when it was created, it was immediately associated with a research unit in Paris. As Giorgio showed, the INSERM unit of Talleyrand, Banco, was associated with the development of SEEG. And so the development of SEEG was fundamentally associated with research. And I think it's important to have always the possibility to immediately, when you have this SEEG team, to have a research team associated with the epilepsy team. What is important is to have in mind that 2 kinds of research, to be schematic, are associated with the SEEG. The first is a pathophysiological research. What is the basis of this disease? I think is typically what a clinician wants to do, is to better understand what is epilepsy, how I can treat better, personalize the treatment of my patient. To do that, we need now technological advances. I mean, to better represent the biomarker of epilepsy, for example, to quantify the signal, to put this biomarker in a neuroimaging vision. That's the side of the pathophysiological approach. And the other side is a more basic scientific approach of the normal brain. That's another story. But this story is dependent on the first one, because if you understand where is the process, you can better understand which kind of information you can extract from the brain of our patient. And the 2 kinds of researchers can discuss together. Probably to be more scientific, we have to standardize the procedure, to have general rules of the indication of the SEEG, where we have to put electrodes, perhaps to have more multimodal approach. I saw this idea to combine TMS and SEEG was very, very bright idea, I think. Maybe to combine also surface recordings and depth recordings, because one of the problems is a sampling problem when you do SEEG. We can develop methods to overcome this problem of sampling. That's maybe modeling or source localization of the SEEG signals. But the question is difficult because I think there are many ways to progress. But the most important thing is to have researcher and clinician in the same site with the same idea of what we want to do, either pathophysiology or study of the physiology.
Thank you so much, Fabrice. Giorgio, since you are the youngest between us, I would like to go back to the history and ask you, when can we date the origins or the graffiti of SEEG?
Thank you, Chico. When STRG was not born overnight. It is a particularly complex procedure methodology, so complex that it was rejected and opposed till recent year with the pretext that electrode, as Florence said, entered the brain. Now we know very well that side effect comparing STRG and subdural grip are far less in STRG cases. So it's less risky. But some premises, if we have to speak when start STRG. Already on December the 7th, 1948, Talairak performed an approach in the death nuclei thalamus in a patient with atrocious pain. 1948. The first implant of stereo EG, so-called, of electrode for epilepsy came more or less 10 years later, on 3 May 1957. And so you understand how long it takes to perform this. And in 1959, they published the first, as far as I know, seizure recorded intracerebrally. Then in 1962, the term STRG was coined. So you understand how long it takes to have the STRG as we know now, even if with the setting of the time. Technically speaking, at the beginning, STRG used the electrode that were 2 millimeters about in diameter. Now the electrodes are 0.8. And it was the so-called acute STRG. I mean, the patient was brought in the operating theater, implanted, awakened, recorded all the day long. This seems because the French law prevented to leave the implant more than 7 hours. So all has to be finished all the day long. And if seizure didn't arrive, they were obtained with injection with Massimini cardiazole or with hyperventilation. In 1959, it was built the first stereotactic room dedicated to STRG. It was called the chapel. I was inside when I was in Paris, a huge room with a very high ceiling, with space to have the teleradiography. You know, the teleradiography means an X-ray tube at 5 meter distance from the head of the patient with the rail, with a kind of so-called frog, the grenouille in French, that move from the frontal position to the ceiling, and this was the first setting of this operating room. When the possibility of steerage became not more acute but chronic, electrodes were 0.8 millimeter, and the patient was moved to the video lab to record seizure, to record the patient for average 10 days till 4 weeks, I think, no more for reason for infection and so on, for problem. And these were the first setting of the time.
Okay, thank you, Giorgio. And now another one for Florian. When do patients become eligible for ECG in terms of age and in terms of epilepsy unfolding?
Yeah, I can try to answer from my limited knowledge on the topic. So I know the guidelines, at least in Germany, and I would imagine that they don't deviate much worldwide. Today still are, unless things have been changed and I have become aware. So the general rule of thumb is you try to perform pre-surgical diagnostics on patients that do not achieve seizure freedom through medication. So the so-called pharmacoresistant epilepsies are the ones for whom usually the greatest chance of achieving permanent seizure freedom is in a surgical procedure. And the rule of thumb is they should have had 2 anti-epileptic drugs. For a while it was one of them should have been one of the more modern ones, not valproate or carbamazepine or phenobarbital. Basically, if you've had 2 drugs in a sufficient dose and do not become seizure-free, then again, the rule of thumb is every additional drug that you try might have a chance of maximum 5% of achieving that. So basically, once you're pharmacoresistant, you're likely to remain that. Please correct me if I'm wrong. You look skeptical. Okay. So that is something that is important to realize. So of course, surgery, cutting out some part of the brain, is much more invasive than taking medication, at least at first glance. Something that might be also important to realize is when we talk about implanting electrodes. So during the pre-surgical diagnostics, the main pillars are structural MRI. If you see a lesion, that's already incredibly good for the prognosis. And then you want to know how many other things fit with that lesion. For example, the semiology, the symptoms during a seizure that a patient or the relatives can report. If there is EEG findings like sharp transient potentials close to that lesion, if, for example, the neuropsychological test battery shows a functional deficit that also points to that region. Examples are if you have a lesion in the left hippocampus, often you have impaired verbal memory. If it's in the right hippocampus, you have impaired spatial memory. If all of this fits together, then typically what you want to do is use the scalp EEG, record a few seizures, and if those match your hypothesis, then typically patients can be offered surgery. And in our center in Bonn, that goes for about 90% of the pre-surgical workups. So it's only less than 10% of these patients that actually need to have electrodes implanted because we're not sure enough otherwise where the area to be resected is. So in terms of when, according to the disease epilepsy, it's simply pharmacorefractory is enough of an indication or to provide an indication for pre-surgical diagnostics. In terms of age, I believe there used to be a feeling that you should wait long enough and perhaps not do this on the maturing brain, but that paradigm, as far as I can judge, I'm not a neuropediatrician, I'm not even a neurologist, has been turned around, because we also know that the development of the brain, of the maturing brain, can be severely impaired by the focal activity, by the activity caused by the epileptic process. So it might actually be incredibly helpful for these children to receive a surgical intervention as early as possible in their lives. So I believe some rethinking has been done there.
Sometimes also not waiting for a classical demonstration of pharmacoresistance. With some pathologies, on the basis, it can be advisable to go on as early as possible.
Okay, Fabrice, so sticking to when, basically you formally talked about research and clinics, the pathophysiological research, the basic research. So basically, when do you think that the aims, the goals of research and clinics best align in stereology procedures?
I think it's a very crucial question, and I remember when I started SCG in 1994, around 94. And after, when Patrick Chauvel arrived in Marseille and developed SCG with, it was associated with the development of a research INSERM team with two objectives, actually. The first is to improve, because when we interpret SCG, we have two main objectives. The first is to define where is the epileptogenic network or zones. We can discuss these names. And the second is where are the functions in the brain. So these two parallel processes are crucial, because at the end you will compare where are the functions in the brain, where is the epileptogenic zone, and if you can operate or not. So the development of research over the last 25 years, I think we are done in these two directions, at least in my lab, but also in many other teams in France and probably in Milan. The first is to develop better method to identify the epileptogenic regions. One of the examples is development of epileptogenicity index, or the quantification of spiking activity. With Nicolas, we have developed a nice software that can be used in the routine, actually. So we start from basic research, engineers, and after we develop tools to be usable by clinicians. So it's very important, because now we can have this vision of these markers of the brain epileptogenicity for each patient that we explore in SCG, in the routine. That's the first part. The second part is to develop with our researcher collaboration good tools to test the main brain function in patients with SCG. I mean, if you collaborate with people doing cognitive neuroscience, we can test better memory. We can develop testing memory during SCG. We can test better language. We have developed language procedure to test during SCG. That's a crucial point. And of course, there are also more basic questions that are developed together. But if you talk about how these two kind of research aligns for the patient, is the convergence between these two aspects. I think it's very crucial. That's what I wanted to impose to the researcher that work in my group, to be useful also for the patients.
Thank you so much, Fabrice. That's exactly my dream, that a team that must to take care of patients must be done not any longer by only medical doctors, but all the figures with the new technologies, new matters. It's very, very important for daily routine, not only for high-level research. So next W. Next W is how.
Wow.
Giorgio, since you have a very long experience, how has the surgical approach to SEG evolved in the last 30 years?
So the basic idea for the surgical approach of stereo EEG was the need to reconstruct the intracranial content for the definition of the two targets that are the target of which every stereotactic procedure. The target that you have to reach and the target that you have to avoid. On one hand, the areas that you have to explore in the brain, and on the other side, of course, the vessel that you have to avoid. The first are the target that you have to explore, of course. So what have Tal-Iraq at the time? At the time, Tal-Iraq had only two kinds of exam, the ventriculography and the angiography. But of course, the ventriculography you see here doesn't allow to see the brain, only the ventricle. But Tal-Iraq found that there are two structures that are more or less always the same, stable, the anterior and the posterior commissure. And on these two structures, he drew the baseline, he proposed the grid, the proportional grid that allowed to divide the brain, the endocranial space, in a given number of rectangles and compared the content of those rectangles with an atlas, his many atlas, in a kind of localization of the, we can call it MR in the pre-MR area. He was able to localize the different structures of the brain. For what concerns the vessel you see directly the vessel. But at this point, another genius joined the Saint-Anne group. He was Gabor Zikla, was an Hungarian refugee that, as a welcome in France, was a doctor in medicine. As a welcome in France, he was obliged to redo all the exam of the medicine to get his degree, and he worked in Saint-Anne. But he studied the stereoscopic view of the different projection of the angiography, so obtain a kind of 3D environment that facilitate a lot the introduction of the electrode in a avascular trajectory. The problem was that at the beginning there were only two projections, face and profile. So they had to work, reconstruct the 3D environment, but with a 2D acquisition. Of course, then arrived in around 1977, the CT scan and then MR. At the beginning, we reconstruct manually those 3D acquisition into the 2D space that was the only that we have the possibility to exploit with the Tal-Iraq technique. But then the next step was the step of direct acquisition of the 3D data, MR, PET, functional MR, and so on. And the same, the direct acquisition of the 3D angiography. And I take the opportunity to thank Chico Cardinale here, because thanks to his work with the co-registration, I remember all the hours that he took to try to fit all. we started in our center to use those 3D acquisition directly in a frameless condition, using the software for the robot to implant, thanks to the robot and the direct acquisition, thanks to its co-registration, to set a methodology that was year in advance of what now is the state of the art of the implantation of the steerage. So this is was the future, and now is the present. Thank you, Dr. Cardinale.
Thank you so much, Giorgio. Thank you so much, Giorgio. Now we have to save time. We have to jump some questions, but I know the way. Florian, I think that learning how to perform a neurosurgical procedure for ECG or a epileptological interpretation of ECG, learning takes much time. It's not a question of going 2 weeks in an expert center. I think it's a long way to learn. Do you agree? Yes or no?
Yes.
Okay.
Small fun fact or fun anecdote. My former boss, Christian Elger, he would describe the job of the epileptologist and the stereotaxic neurosurgeon in such a way the implantation is something you could train a monkey to do.
Yeah, thank you so much.
Sticking to how, Fabrice, today we are facing artificial intelligence and the automation of several procedures. So basically, what's the contribution that you expect AI can give and can bring into a CEG, and how far are we from some kind of automatization of stereo EEG interpretation?
I think it's a difficult question because we expect a lot from artificial intelligence, of course. We are in a society that use a lot this kind of procedure. I would say that there are different levels. First of all, maybe we could develop some algorithm at the level of indication of ECG. Maybe there are some tools that are tested to know when we have to indicate or not a CEG. Maybe it could be more automatized, I don't know, but because there are a lot of variability, heterogeneity of patients. That's the first level. The second level is the interpretation itself. Interpretation itself maybe help, I think, for putting into models the enterectal activity, for example, because we have thousands of events that could be more automatically analyzed and maybe put into artificial intelligence software, I don't know. But we are today probably not very far from this step to have automatized software that could give us a distribution of enterectal activity. For seizure activity, probably it's more difficult because of the great heterogeneity of the patterns of the anatomical distribution. So as you know, we developed currently a digital brain twin called virtual epileptic patient, which is a sort of artificial intelligence. Use some methods of the artificial intelligence, and the idea is to keep data from the patient, neuroimaging data, to keep SEG data, to put it into the model, and at the end of the procedure, you have a solution of your SEG. That means that the model gives you the main brain region involved in seizure genesis. So that can be now automatized, and we currently work into a software that could be industrially produced and maybe given to the different centers. So it's not science fiction. I think in the near future we could have such tools available. Yes.
Okay, thank you, Fabrice. So, now, who cares if we jump some other questions? For example, the which question? It's better to jump directly to the last one. Pietro, please.
Yeah. I knew you were the right choice as a co-moderator. So basically, let's spare the few remaining minutes for the very last question, that is the why. Given all what we said and what also we have not the time to say, but basically a common question to all the three of you. So why we are here, and Giorgio saying because you forced me is not allowed. Okay. And so why such an exchange, such opportunities of exchange and real confrontation between clinicians and researchers could enrich reciprocally the experience of stereo EEG people involved. Giorgio, starting from you.
I don't know, perhaps I should do the last because let me be provocative. My view is that stereo EEG will not last forever. That's why I found it a very nice tool for knowledge. It seemed to me destined to self-destruction. I mean, more we know using stereo EEG, more we advance in knowledge, more we advance in expertise, less we use stereo EEG. In Paris, we implanted 100% of patients. When we moved in Grenoble, we implanted 60% of patients. And now in Milano, we are far less 40%. Am I right? Yeah. Okay. Okay, but more. I think that we'll probably arrive at obtaining a non-invasive exam. Perhaps I can imagine a MR with kind of post-processing or with a special acquisition that in the future will tell us what is the epileptogenic zone, which boundary has this epileptogenic zone, so we can operate directly on the basis of this non-invasive exam. At the time, you understand that if not for therapeutic reason, I mean introducing the electrode to burn some nodule, something like this, we will be no more allowed to implant a patient. For which reason? For science, for knowledge, it's impossible. So I think that we have, anyway, a limited amount of time. This could be a kind of science fiction, but I think that at a given moment something arrives and we are not aware that they are arriving. But anyway, they arrive. Let's imagine before the era of MR, CT scan, how one can imagine the possibility to see directly into the brain. So the question, why we are here? I think that we are here to ensure that the collaboration between clinicians and researchers is even closer and more fruitful than ever. Because the amount of data that we have from stereo EEG, I think the use for clinical purpose, 10%, 20%, I don't know, million of data. Neuroscientists are happy to receive those data and to elaborate those data for advancing knowledge. But in a moment, they will not have more those data. So we have to hurry in our collaboration. Thank you.
Fabrice?
Why we are here? That's a question.
Same question.
Why not?
Perfect.
Is it enough short for you? No, I completely agree with Giorgio, but the ultimate goal should be to avoid SCEG, actually. And one of my dreams should be to develop a brain model, SCEG, completely virtual brain model, based only on non-invasive techniques. That means that we could inject into your model the data from the semiology, from the video EEG, from the MEG, from the PET, etc., MRI. And at the end, your process, you see a virtual SCEG, and it's enough to operate the patient. That could be the ideal situation. I think we are a bit far from this situation, and in the future, probably we will need to implant patients. The proportion of patients to be implanted has increased in the world, but I think it's due to the fact that many teams have discovered SCEG. And I think we really have to make effort on the indication of SCEG. But probably we implant too much patients. I see some discussion in some meetings. I see some cases that are implanted why probably the solution can be guessed before the SCEG, but it's not operable, etc. So that's a point, the development of techniques to avoid SCEG. And the second, of course, is to interact between researcher and clinician and neurosurgeon into all this very rich environment. For example, there are some phenomena that arise from the SCEG exploration of patients by the stimulation. We did not talk about stimulation a lot today, but there are phenomena that cannot be reproduced experimentally. The déjà vu. The déjà vu is a very nice phenomenon that is extremely difficult to reproduce in the lab. But if you stimulate the entorhinal cortex or the hippocampus, the amygdala, you can reproduce this sort of reminiscence of memory and work on the connectivity, what happens in the brain during this phenomenon. But if you work only as a clinician, you will have a limited knowledge on the memory system, etc. So that's an experience that I had. I worked on this phenomenon some years ago because I was also in collaboration with people that were specialists in memory. And we exchanged together to try to understand what happens in the brain, what is this strange phenomenon, etc. So this is an example of something that we can have during the exploration of SCEG, but will feed the collaboration with research. And there are many examples, ecstatic phenomenon, the basal temporal regions, etc., etc., in the story of SCEG.
Yeah. Florian.
Okay, so first of all, I agree with Fabrice and Giorgio that the time window for invasive brain recordings might be limited, right? As non-invasive methods get better and better, we might see an end of that rather sooner than later. And of course, it'll be beneficial for the patients. And also, it has been said, scientific curiosity will never be a justification to put electrodes in brains. And if we think about the fact that there has been a flourishing animal electrophysiology for over 70 years, where we put electrodes into animal brains, and we don't do that because we're so incredibly interested in the inner workings of the rat's brain or the monkey brain, but because we feel we can learn something about our own brains. Now we have a short time window in which there is a possibility to actually validate that and see if it's correct or not. And there is a reason why in the animals nobody puts in macro electrodes, but rather microwires to record single neuron activity and see how they relate to ongoing oscillations in the brain. And that is possible in the human brain, but very few centers are actually exploiting that possibility. And especially given that it is a limited time window, I think that's a pity, if not a shame, because the initial results we're getting actually put some question marks, for example, on the validity of rodent navigation as a model for human episodic memory. But since there are very few voices saying that, it's easy to overhear them. There's a multi-million-dollar industry that does not want to hear that their primary assumption is wrong. So I think I would love to see more centers. I don't think there's a reason. Whenever you insert an electrode, it should also be possible to add microwires to it. I think we can all agree the additional risk is negligible, and the benefit for science and epileptology could be immense. Yeah. And having said that, if anyone's ever interested to learn this type of technology, please come to Bonn. I'll be happy to show you and tell you all my tricks and experiences. Any center that is interested in using microwires is welcome to visit me.
This was the other.
Yeah, exactly.
Perfect. Okay, guys. Time runs fast. I would say once again, thanks to the three of you for joining us and helping us in getting this picture. Florian, a double thank you for the flexibility, let's say, of you. And I'd leave the stage to Andrea for presenting the last speaker of the day. Okay.
Today I'm responsible for the most difficult introduction. I'm introducing one of the most influent scientists in the field of intracranial recording in humans. Dr. Parvizi is a clinical neurologist at Stanford University, where he directs the Stanford program for refractory epilepsy and leads the Laboratory of Behavior and Cognitive Neuroscience, investigating brain function and behavior. He earned his medical degree from the University of Oslo and completed the PhD at the University of Iowa under mentorship of Dr. Antonio Damasio and Dr. Gary Van Hosen. He further trained at the Mayo Clinic and Harvard University before specializing in epilepsy at the UCLA. And since 2007, he has been a distinguished member of Stanford Department of Neurology and Neurological Sciences. With over 100 publications and more than 6,000 citations, he ranks among the most influential scientists in the field of human intracerebral stimulation and recording. It is both a privilege and an enormous pleasure to me to now welcome Dr. Parvizi to the stage.
Valerio, Professor Parvizi is presenting from the laptop here. And also please switch the figure there, please.
Well, while we are connecting, I would love to disagree with the entire panel saying that days of IEEG are counted. I think the other way around, since at Stanford we have started implanting psychiatric patients. So I think, yes, you're right, we may find remedies for patients with epilepsy, but intracranial EEG is here to stay, and we are going to perhaps expand it to other neuropsychiatric conditions. And for students who are interested in this field, I encourage you to pursue a career in intracranial electrophysiology, because that's going to give us quite a lot of information about the human brain that we cannot get with neuroimaging unless you put your patients in the scanner for 2,000 hours. I do agree with Fabrice that a day will come that we will non-invasively create a virtual SEEG, but unfortunately the signal-to-noise ratio with the MRI is unbeatable. You can't actually, you can't override the rules of physics. Unless you create a scanner that gives us a better signal-to-noise, unfortunately, it's going to be impossible to individualize the map. You can get group-based images, group-based maps, but that cannot translate to human native space. So that's a topic that we would love to consider for discussions. But I'd like to start with a question of what is epilepsy for the students in the audience. I would like to give you a couple of introductory slides to familiarize yourself with patients who are subject to intracranial recordings. We used to say epilepsy is a condition of having more than 2 seizures spread in time and so on. But right now you can call a patient epileptic if they have had only 1 seizure, and then MRI shows that they have a condition that basically increases the probability of seizures in the future by more than 60%. About 1% of the population suffers from this disorder. Seizures are very similar within the same patient, what we call stereotypy, which basically means that they are the seizure waves, they are originating from one place and then they are traveling, as Hewling-Jackson beautifully predicted, from focal seizure. They propagate to areas that are paved anatomically, and that is why the semiology or the signs of seizures will remain very stable from one seizure to another. But every patient can have different type, or patients with certain types of epilepsy will have very different semiology than patients with a different kind of epilepsy. This is a patient of mine who was a very successful, he competed in surfing, and he came to UCLA for monitoring. We diagnosed him with frontal lobe epilepsy. It only happens during sleep. They are trying to wake him up.
Julie, hey, it's time to give you your meds.
The leg, right leg, the voice, the arms.
I'm going to give you a word to remember. Apple. Can you tell me your name?
That's it.
Can you tell me your name? Can you tell me your name?
See how similar it is? It's in a different day.
Go back, honey. Go back. Lay back. It's okay. Lay back. Lay back.
See, it always ends with him covering himself. He's not aware of these events.
You okay?
Because of the contractions in diaphragm, he's exhibiting this type of sound. His partner thought that there is something psychiatrically wrong, and they couldn't sleep in the same bed until he comes, and then a diagnosis is made, and he becomes candidate for surgery and seizure freedom. But every seizure can be very different in one patient than the other. This is his seizure. Basically just a tonic flexion of the neck. And that happens with the whole body, and they fall and crack their head, and many of them die. Even though it is a very simple thing, it happens only a few seconds in a year, in a month. It is so unpredictable and so severely disabling that these patients basically lose their job and they become chronically dependent. This is a temporal lobe seizure. He knows that he's having a seizure, which we call auras, which is a small seizure. If you had a depth electrode, you could see that the hippocampus has been seizing for tens of seconds. Now he goes into oro-alimentary automatisms with hand as well as lips and so on, and loses awareness. This is a very different kind. Lastly, one more seizure of frontal kind, just to give you a flavor of types of patients that we see in our clinic and we send to epilepsy surgery. This is called the rocking movement or pedaling movement, very typical for frontal lobe epilepsy. We are very thankful to these patients who are coming to us and volunteering their time for research during their events. And we need to really have empathy for what they go through. Imagine you have a disease of this kind and you go through this type of storm that is generated in the brain. Now I'm going to ask you to think about his brain from inside, and let's listen to sonification of seizure that goes from left to right with the heartbeat. Can we get a little bit more volume, please? Volume up. You are hearing the heartbeat. No? Anyway, we can't hear the sound very well. This is created in stereo. I wish we had the sound, but it's a storm. It's a storm that basically seizes the mind of a patient. That's why it's called seizure. It stops everything else. About 30% of these patients, as my colleagues referred to, are candidate for what we call alternative therapies because they are pharmacoresistant. And this is a beautiful work from Israel showing how the chances of seizure freedom diminishes as they fail number of anti-epileptic drugs. What happens to these patients is that a referral is made usually to a tertiary center. After clinic visit, they go to an epilepsy monitoring unit. We do tons of studies on these patients. And for the editors of journals over here and for some reviewers, if you are unfamiliar with epilepsy, please don't criticize the work in terms of, oh gosh, like the whole brain is corrupt, the whole brain is problematic, epileptic brains are not good models, there are tons of seizures coming from everywhere. Not really. We don't implant everyone, and we don't implant unless all these lines of evidence suggest focality, meaning only one network of the brain is affected, the rest of the brain is not. And then we basically do the invasive monitoring in order to know exactly where to go and what to do. Now that I've promised to talk a little bit history of neuroscience, let me take you on a little bit of a tour, why we do invasive monitoring. Well, I can tell you one sad story of a real patient who went to a hospital in the United States. They did scalp EEG. They found that patient has limbic type of seizures, and all these signals are coming from the left temporal lobe, even though he was left language dominant at a very young age, about 15 years old. They did a WADA test that suggested that he could tolerate, meaning he would not be globally amnestic if they did left temporal lobectomy. They did left temporal lobectomy. His lexical memory diminished significantly, but he was seizure-free only for a few months, then his seizures returned. Several years later, once he became 18 years old, he was referred to my clinic since I'm an adult epileptologist. And one day, we were just beginning to really do investigations in this patient's case. He has a seizure. His mom tries to take him to the hospital instead of calling 911 because ambulance ride can be quite expensive in the United States, depending on your insurance. In the freeway, unfortunately, they crash. Mom dies. And he comes to the hospital, and we do invasive monitoring, and we discover that actually his seizures are coming from the insula. So if they had done invasive monitoring before they took this poor guy's left temporal lobe, he would have actually gained seizure freedom, he wouldn't have lost his language skills, and he would have become most likely seizure-free, which he is now, and he would have perhaps kept his mom. So that's really the story behind all this invasiveness. And of course, another sad story that you all have heard is the story of HM, which brings us to really what we have learned from these patients in the history of neuroscience. Patient HM basically initiated this huge fire in terms of our knowledge in literature about hippocampus and memory. Before this case, very little was known about the medial temporal lobe and memory, but look at the number of publications that have been published since patient HM. So another contribution that these patients are very well known, you know about the lateralization of functions from left and right. That comes from patients with epilepsy who had to go through corpus callosotomy. And you see before 1956, very little was published about lateralization of function. Lastly, one more example of what patients have contributed is really to this controversial notion of localization of functions. Since it's the end of the day and I've promised to go very light and tell you just stories, let me take you on a trip about this whole epilepsy surgery business and invasive recording, how Penfield came up with this idea of grids and strips, as my colleagues were talking about. Penfield was very interested from get-go about the human mind. He was one of those neurosurgeons that went to neurosurgery because he was curious. He wanted to understand the human brain. And his interests are actually shown in who he decided to go and study with. When he was at Oxford, he had the privilege of being Sherrington's student. Those days, Sherrington was using electrical stimulation in monkeys and mapping the entire motor cortex. Sherrington has beautifully mapped the primary motor cortex, but he failed to map the sensory cortex in monkeys because monkeys could not tell that their hand was tingling. Now their leg is tingling. And that is what basically brought Penfield into the business with the somatotopic organization of the sensory cortex. He was a student of Sherrington and learned that method from him. And again, as this was mentioned by Giorgio, Dr. Forster in Germany was the one who actually started the business of epilepsy surgery. He used to open the head and start poking with electricity, and patients are awake, and patients could tell, oh, now I have my typical aura, or now I have my typical seizure. Okay, let's go and cut a little bit around this, and that would perhaps do it on these patients. And that was the electrically induced auras as a way of mapping the brain. Now, you guys are scientists. If you do an electrode over the brain and record during cortical activation, you are recording something like this. You have fancy computers, you have fancy amplifiers. You can go as high as 300, 400 hertz. Your recordings are 1,000 samples per second. But during Penfield, this was not seen. All he could see from EEG was actually this, because he didn't have the amplifiers. For him, EEG was piece of crap. He did not like EEG. He went to business of neurosurgery because he wanted to understand the human mind. That is why he stuck with electrical stimulation. He loved electrical stimulation. He hated EEG. It was only because of Jasper that he allowed this type of recording, so-called intracerebral EEG, to be performed during his operations, because and only because this could tell them about the presence of spikes, which was another basically way of knowing where the epileptic zone is. This was way advanced compared to Ottfried Forster's method of electrically stimulating and inducing auras, because we know not all epilepsies are accompanied by auras. So because of spike chasing, which later, by the way, as Florian mentioned, it went on and became basically the way to do epilepsy surgery at Yale with very influential surgeons. And now that my colleague Gonzalez is not here, I can bash Cleveland Clinic and say that Cleveland Clinic was also one of the forts in the United States that protected the business of Penfieldian type of electrocorticography, did not want stereo EEG in the United States. That story changed when Paul Chauvel was invited to join Cleveland Clinic and stereo EEG revolution in the United States. But so because of spike chasing, this method basically became the norm during American practice of neurology, whereas as Giorgio so beautifully described, something different was happening in France. They were chasing something very different, and that's what we now call stereo EEG, which has to do with the implantation of these electrodes, and that is a French revolution in neurology, which has basically taken over the United States. You were talking about what will happen in the US. This is the chart that my surgery friend, Dr. Vivek Puch, and I published. You see the red is the practice of stereo EEG at Stanford, and blue is the practice of electrocorticography. And this is happening in the United States across many hospitals. Part of the reason is also because of money. If you do stereo EEG, you can finish the surgery within 2 hours, especially with robotics. But if you do electrocorticography, it takes many hours. It takes a lot of pain meds. They have to go to ICU. You use a lot of healthcare resources for this, but the hospital really prefers stereo EEG, and they encourage it. And that's why in the American industrialized business of healthcare practice, stereo EEG is here to stay. Just to tell you a little bit from, this is what, Giorgio, what we consider as the story of SEEG in France, so please correct me during the break. But what Talerac basically did was to build on the stereotactic, basically science that was developed with this wonderful frame that was developed for animals by Horsley and Clark. This was very limited, unfortunately, because it depended on landmarks over the skull, basically external landmarks. But a beautiful discovery was made at Temple by a Jewish scientist that was chased away from Germany and luckily landed in the United States. And they developed internally based a stereotactic frame that did not depend on external markers, because external markers are very variable, as phrenologists, of course, very famously studied. Every skull is different, every person could be different, but internal structures such as the ventricles and commissures, they can be quite stable. And that is how the French school, under the leadership of Talerac, started this stereo EEG business, and we are so thankful that they have done it so. This is very hypothetical, but I think one other reason, Florian said that American neurology and neurosurgery practice was worried about penetrating the brain, but also American neurology, coming from the British and all the English textbooks, they were quite Victorian. As you see, during Victorian era, the way that the evolution and Darwinian notion of evolution was misinterpreted by Herbert Spencer, who coined the term survival of the fittest. that wasn't Darwin. It was actually Herbert Spencer, the philosopher, who termed it. And he was the social Darwinist who believed that certain societies like the Queen Victoria Society should rule over chaotic other lowling, basically, systems. And then Hugh Jackson, who was a best pen friend of, wrote a lot of letters and had exchanged with Herbert Spencer, to some extent brought social Darwinism into neurology. If you look at Hugh Jackson and the Victorian era British neurology, it's all about top-down. And that is how Freud, for example, got so influenced about this whole superego id, as if like we have beasts that are shackled in the brainstem and we have to constantly inhibit them. Such a stupid idea, because such a system is economically just not wise. Why do you have a system that tries to do something like Home Alone kid, and the top cortex has to constantly inhibit it, and if you disinhibit, you become disinhibited. So for those of you who are interested, I have written a paper that has probably 2 or 3 references, which is self-referenced by myself. It's in social neuroscience. It's called Disinhibition More Than a Misnomer. That's where I have basically talked about this whole unfortunately flawed view of cortex and subcortex, yet we forget that actually a lot of this is very colorfully, very beautifully coming from bottom up. So maybe that Victorian culture also basically provided some sort of incentive for the British and American practice to basically value the cortex and the cortical with the grid and strips and so on. But the French school was perhaps free from that. This is total hypothesis that cannot be tested. So something else has happened with stereo EEG that has broken the corticocentric myopic view. And here I have to thank this gentleman, Fabrice, who did something revolutionary in our practice. If you haven't noticed, he was the guy who started the business of basically saying, okay, guys, we are implanting all these electrodes to see where the seizures are beginning from. Let's extend one of the electrodes to reach the subcortical structures such as the thalamus. And that actually was 20 years ago, and he started this business and showed how thalamus is really key and important structure that's really involved during seizures. And then somebody in University of Alabama, a great guy, Sandeep Pati, basically got inspired by Fabrice's work, and they started doing it in Alabama. An editorial was written about why other people are not doing this in the United States. At Stanford, we stood up and said, yes, we would love to do it. And we basically modified Fabrice's method by extending not only 1, but extending 3 on each side. So we have the anterior, mid, and posterior thalamus, and we can simultaneously actually see how different nuclei of the thalamus are involved. I'm hoping that this stereo EEG business, and with this extension of electrodes into the subcortical areas, we will one day understand a lot more about the role of subcortical structures in propagating seizures. We will understand how we can go and put neuromodulators in some of these switchboard nuclei to stop propagation of seizures. So this is what we do with EEG, just to give you an example. A patient comes in, we put these electrodes, some of these electrodes are in the thalamus, then they have to wait for their seizures to come. And this is a great time to be entertained by graduate students and postdoctoral fellows. They go in with cookies, coffee, everything, almost like concierge service. We have a dedicated research assistant. They go and talk with the patients and so on. And they ask if they have time to do a task. A task is not basically a painful experiment. It's just a computer that they had to play with. This is like one of those times when we had asked the patient to repeat certain word stimuli. This is a task that I was collaborating with Professor Bob Knight at Berkeley. And unfortunately, I don't know. Oh, I will be quiet. So,
Flat.
For those of you who are not neurologists, you look at the EEGs. This is one needle or one shaft, electrode 1 and 2, 2 and 3, 4, blah, blah, blah. So this is the closer to the surface of the brain. This is deep down, and you can actually see that the seizure has already started. We didn't know. MRI was negative. And I will tell you a story of this patient, and you'll see why we are doing what we are doing. And now we know that before this is the left brain, this is the right brain, and you can see that the seizure starts from one and specifically that electrode. And if this is the case across multiple seizures during the operation, then we know exactly where the seizure onset zone is, at least based on the sampling that we have, as long as we have put it in the right place. So here is a patient who's doing cognitive testing and seizure has started. Pay attention to what happens when amygdala goes into storm. Hippocampus is going to be next. Posterior hippocampus is going to go. Then pay attention to the lateral cortical electrodes are going to go next. This is like the staging of the play. Starts from the amygdala and then goes on. This patient is instructed to repeat words that she's hearing.
Riches.
Riches.
Guilty.
Guilty.
She's repeating guilty.
Matriarch.
Seizures are getting bigger and bigger.
Cruel.
Cruel.
Deep.
Deep.
Basically, you don't notice at all that she's having seizure. She's performing the task perfectly well.
Hard.
Hard.
Tragedy.
Tragedy.
Fast forward.
Indoor.
Indoor. Okay.
Amateur.
Amateur.
Now the left side is going
Angel.
to begin. Patient stops.
Fearful. Grin.
Doesn't respond.
Seen me doing that.
And then she utters a sentence that basically tells every time the family that I'm having a seizure. She says, "You haven't seen me doing that before. You haven't seen me doing that before." We call it speech automatism. And you see, now it started from the middle of amygdala, then now it is the entire right cortex, at least temporal lobe is seizing. Right there, she's responding perfectly. She knows the task, she knows what to do, and you don't even notice that the patient is having a seizure. And then, as the right side continues with seizure and the left side starts, now she's almost like patient HM. To some extent, you're shutting down both medial temporal lobe, and here, this side is postictal, here, left side continues. Then she starts getting confused. She doesn't know where she is. She starts ripping off her IVs, wants to get out of the bed, and so on. And this is the story of her every time she has a seizure. This patient that you cannot see the face was about to get divorced. She was a very famous TV anchor and came to Stanford. She was severely depressed. She was on 2 antidepressants, 3 or 4 anti-seizure medications. We did this surgery, and she sent me this picture on the anniversary of her seizure freedom. She and her husband went to a renewed honeymoon in Hawaii, and she has been seizure-free ever since, more than 15 years now. So we are doing something for these people, and I personally think, yes, you're right, from going from Paris to Grenoble to Milan, yes, you're right, Giorgio, the number of epileptic patients that we filter out and we go into neuromodulation without SEEG from 100% to 40%, but there are a lot more patients that will benefit from this as the business of stereo EEG is taking off. And I think one day psychiatric patients are going to be next. We will understand the network for OCD, for depression, And pain will be another topic. We have, for example, implanted patients with pain syndrome. These patients are completely miserable, and you don't know what neuromodulation you're going to offer. This is a perfect time to bring them in, implant the electrodes where you're planning to put the neuromodulation, and then put some other electrodes nearby and other places, and then you test it. You test what you're planning to offer them as a permanent treatment during the 1 week of stereo EEG, and patients will tell you which modality is good, etc., etc. With the thalamic recordings that we are doing, we have now turned the business of neuromodulation, of thalamic stimulations, into a personalized neuromodulation. Not every patient's seizures travel through anterior nucleus, yet everybody has been taught in classrooms, go and implant the anterior nuclei and for neuromodulation of these patients. So personalized therapies that we will offer will basically go for a while. I cannot tell you for how long, since I'm not a forecaster. But I've given you at least examples of how these patients have contributed to neuroscience. And I haven't touched upon many other areas where these patients have actually contributed. Just think about how much we have evolved in terms of EEG knowledge and electroencephalography research. Think about how much we know about neuronal population code, thanks to recording from these patients. And because we have implanted multiple areas, now we can see how different regions of the brain work together. And think about neuromodulation therapies and all sorts of stimulations that we are applying to the brain and understanding the effect of multiple types of neuromodulations. Think about brain-machine interface, the business of BMI right now, and how much these patients are contributing. And of course, what makes me super, super excited is actually the business of causality. Because I think you will never, ever get this type of knowledge with fMRI or any other correlative research. This is a paper that we wrote in Nature Reviews Neuroscience, and there are multiple facets of causality that you can try with electrical stimulation. Yes, you're right, we haven't talked anything about electrical stimulation, but hopefully I will talk a little bit more in my Thursday lecture, just to finish by one story of how this type of causal information is important. Of course, you have seen the controversy in research of face areas. Some people say, well, the face area can also light up in car salesmen. Yes, of course, cars look like faces from the front. So, but you don't know exactly how much this area is important for faces in causal term. Here is what happens when you have electrodes in the face patch. This is a work that we did in collaboration with Kalanit Spector at Stanford. Patient is looking at my face while I'm stimulating their face patch.
3. You just turned into somebody else. Your face metamorphosed. Your nose got saggy, went to the left. You almost looked like somebody I'd seen before, but somebody different. That was a trip.
Did I keep my gender?
Yeah. Oh, yeah.
How did you know I'm not a female?
Because you're still wearing a suit and tie.
Oh, you could see the suit and tie?
Yeah. Only your face changed. Everything else was the same.
We did quite a bit of control and we stimulated only the face changes. We showed them, for example, car pictures and so on and so on. And later on, we have actually shown how the best selective sites across patients, where they are located, and how the time of this is the selectivity. So here is the XY, basically that is where the best selective site is. And if you look at all other activated sites, they are far less selective than the best selective one. And then if you put them in the MNI coordinate and look at their response onset latency, you see that the best selective site activates to the face first, and then later the other one. It's as if like this, at the time issue, that you have this temporal propagation of face information. Now, if you are Haxby and you are using PET scanner with a time resolution of several seconds, you get the entire temporal lobe, you take the best selective sites and filter them out, and then you ask the computer, is it face or not face? Of course it is face. But that doesn't mean that information is distributed as if everybody is contributing equally. It just means that it got distributed in the time frame of PET scanner, and now it is available almost everywhere and not in the face selective sites. But now, what happens, this is where causality is important. What happens if I go and stimulate? If you stimulate all these face active sites, nothing happens to the person's subjective conscious experience of your face. It only happens when you stimulate the best selective one. And not only that, it only happens if you stimulate the posterior best selective one. So there are two patches, one is MFOS, the other one PFOS. It only happens when you stimulate the PFOS. As if the more closer you are to the incoming sensory basically information, that is where you can disturb the consciousness of the patient. And I will talk on Thursday about how we have learned about the brain basis for sense of self and subjective experience, what we have learned from these. So we are grateful to these patients, and we are so delighted that they are taking us to way new horizons. And I think this business is here to stay, and let us be very optimistic that we are involved in a business that helps alleviate patients' suffering, but at the same time, it takes us to a journey about the brain and about the human mind and human consciousness. Thank you.
Thank you, Professor Parvizi, for this very inspiring lesson. Thank you for sharing also all these experiences with us. Is there any question for Professor Parvizi?
I'm particularly interested in one of the last topics that you mentioned, the causality testing in humans, and in particular the idea that we can stimulate in different ways. And many times we need trains of stimuli to elicit the kind of perception that you mentioned, like the change of face. But there is also a bunch of literature showing that with single pulses, we have about half a second in which the stimulated area seems to be dysfunctional, at least from a spiking perspective. I was wondering if you have any thought on this kind of mismatch between the single pulse that creates the neuronal dysfunction, but not the perception.
Right. Yes, you're right. We can only disturb at least the subjective perceptual experience if we stimulate at frequencies above 20 hertz for a period of time that subject will experience that something changed in their experience. So if you do very single pulse for, let's say, pulse width is going to be at the most 1,000, right? So it's going to be too short, perhaps, and also it's going to be just one pulse. Yes, it's going to cause some sort of problem very locally in that neuronal population, but you and I know, we are not phrenologists. The face is not just located in the face patch. It is the network associated with that and how much effect you can actually drive within the network that will basically tell you if the subject is going to perceive a change or not. So what I believe is, number one, it's too short. Number two, it's too local, and it doesn't have enough energy to go into the network, and this is a network effect. But I don't know the right answer because we know so little about electrical stimulation, that actually less so than EEG.
Thank you so much for your talk. It was amazing.
I had a question for you about the psychiatric implications. Since that's also my area of interest, I was curious to know, in your mind, what's the biggest challenge we're going to face there? And in particular, I think we're going to have this tension between something that's very personalized to that patient, but also we want to discover something that's general, that like we can apply and maybe use then TMS and like non-invasive techniques to cure. So I was curious to hear more from you on that.
Just copying Florian, I'm not the expert, so I can't explain. I'm not a psychiatrist. A psychiatry team at Stanford, led by our neurosurgeon, Dr. Butch, and our psychiatry colleague, Dr. Carl Diceroth, are running that. I don't know what challenges they face, but so I cannot answer that question, but you're right. There should be some challenges there. In terms of personalized versus generalizable knowledge, yes, you're absolutely right. The knowledge we gain about the brain and how different networks are working can be generalizable. Because if you see consistent pattern across multiple patients, for example, when we are submitting publications, usually, you know, in the field of monkey electrophysiology, you usually have either one monkey or two monkey, and you have Maestro Rizzolatti is here. He can teach us how elegantly they do it in monkeys. In humans, we have 4 or 5 patients with different types of epilepsies, and we show exactly the same pattern across patients with different types of epilepsies. That's generalizable. But when it comes to therapeutics, I think we need to really respect individual brain as much as we can, because sometimes very generalized therapies, one shoe doesn't fit all. That's what I meant, only when it comes to therapeutics, to personalize it.
Okay, we have another question there.
Thank you for your talk. So it's a question related to stimulations and to the clinical effects. So in a very small percentage, when we resect the area that has a clinical effect, when we elicit it by stimulation, we get a post-surgical deficit. We know this is due to the network effect, but what do you think we can do better to map the functions of the brain that we are supposed to resect and to anticipate the post-surgical deficit?
If I understand your question, you're asking how we can forecast, how we can foresee what deficits they are going to have. Right. So that's where we could potentially do at the bedside. We could use electrical stimulation as one way of disturbing that area and see if electrical stimulation of the region will literally cause deficits. Something that was done by Ogerman and others in Washington, for example, before age of fMRI, to map where the language network is. If they saw speech arrest, they basically avoided that area because they know if they resect that area, they will cause speech impairment. We could do this with other cognitive functions as well. The problem is that many clinicians are not very savvy with testing higher cognitive functions than just language and certain motoric things, you know, raise your hand or repeat after me. They can't really do sophisticated studies of parietal lobe function to foresee what will happen if they resect intraparietal sulcus. That is why we are here. So we can actually, this is where scientists need to come and help. At Stanford, everything we do scientifically with cognitive tasks of language, memory, math, face perception, etc., we actually share all that knowledge with the clinicians. Just to give you one example, and I promise to be very short and shut up after this.
Oh, please.
So I know everybody's hungry and thirsty and jet lagged, but we had a patient who came in, and this patient had intracranial electrodes, was 100% right-handed. We had put electrodes, and we were trying to see if it's the left side or the right side that's causing the seizure. We didn't know. We knew that patient has temporal lobe epilepsy, but we were not sure. Evidence was kind of confusing.
So we have these electrodes and we discovered that it's the right side and all her seizures are right side. 90% of spikes are from the right side. Okay, case closed. Patient goes to right temporal laser ablation. Right before we were doing stimulations and experiments, we discovered that the right inferior temporal lobe was hyperactive to wards. Ward stimuli activated the temporal lobe a lot more, as if you're recording from ward form area. I went in and found the face area and we stimulated it and we have published it. If you stimulate the face area, you can only perturb conscious perception of faces if you are in the non-language dominant hemisphere. So I was on the right hemisphere, non-language dominant, I thought, okay, because patient is 100% right-handed, so chances of right language in this patient was very little. We stimulated, nothing happens. Are you sure? No, your face is perfectly fine. I see a little bit of like dots here and there, but that's perfect example of left hemisphere response. So we went to this patient and patient was a teacher. We said, well, we can send you to right temporal resection or laser, but let us tell you that research is showing that there's something atypical about you. Might be risky to do the laser. She said, oh, absolutely, do not cut or laser anything if it's risky. We said, okay, we can actually find out. Let's do WADA. While electrodes are in place, we go to the WADA test, and as it happens, surgeon can't do WADA because of tortuous arteries or what, said WADA fails. What should we do? We can't do fMRI with electrodes in place. She said, well, pull the electrodes up, send me to fMRI in a month. We sent her for fMRI. She's perfectly right language dominant. And if we had cut the right temporal lobe, it would have been perhaps quite devastating for a teacher in a high school. So she decided to go for responsive neurostimulation rather than laser. And this is why we are here. And I think as a scientist, if you are just a PhD, please take pride in sharing your knowledge with the clinicians, and please encourage your clinicians to value what you're finding at the bedside. So we need to benefit the patients that are volunteering their time by sharing our findings with the clinicians. I know this can be slippery. I know some of you guys are not very comfortable because you think this is research only. I don't want to take any risk, but please share your knowledge with the clinicians. Thank you.
Just a couple of infos.
Thanks again, Professor Parvizi. We are ready for the aperitif. Just a couple of practical information before we end the session. So outside we have an aperitivo that is basically until 7:30 to 8. This night we have reserved a couple of rooms in a club in Parma Center. It is the Giovane Italia. Basically, you all should have received via email the invitation, the address, and a QR code where you should free register yourself to access the club. In case you have questions, we have 2 volunteers, that is Maria and Arturo. Please raise your hands, that are available for providing you all the needed information. For those of you who has submitted a poster, please remember that tomorrow evening we have the poster session in the afternoon, but please feel free to hang on your posters tomorrow morning in the room where we had the coffee break this afternoon. Last but not least, I remind you that on Thursday evening we have the social dinner. It is in a restaurant nearby here, but we will have a couple of buses leading us there. Many of you has already registered. Tomorrow morning, not later than the registering session, we will close the dinner bookings. So anybody of you who is interested in attending the social dinner and has not booked it yet, please contact Nancy or us this evening, not later tomorrow morning. Thank you all for attending this first afternoon. I hope you enjoyed and were inspired for the prosecution of and the continuing of the session, and enjoy the aperitivo.